on bending forward. On palpation, examined is in sitting position, in semi-recumbent position, and in recumbent position. The left breast and nipple areola complex is normal. The right breast, there is no local rise of temperature, no tenderness noted over the lump. Inspectory findings are confirmed with a solitary large right breast lump involving the upper outer quadrant, dimensions being 22 centimeters in the vertical and 14 centimeters in the horizontal plane. The right breast lump is occupying entire right upper quadrant, and there is slight extension into the upper inner and lower outer quadrants, approximately 7 to 1 o'clock position, and it is about 2 to 3 centimeters above the nipple areola complex. On palpation, the further surface is lobulated, margins are well made out and irregular. It is firm to hard in consistency, mobile in the horizontal and vertical planes over the pectoralis major muscle. There is no evidence of restricted mobility after the contraction of the pectoralis. The skin of the lump is pinchable, and there are no lesions noted in the inframammary fold. The nipple areola complex is normal, and the second swelling, which was seen on inspection, on palpation was it was a right axillary swelling, no local rise in temperature, non-tender. It is oval in shape and 6 by 3 centimeters just behind the anterior axillary fold. It is mobile with well-defined margins, soft in consistency. Skin over the swelling is pinchable. No other palpable swellings are present in the breast or axilla. The supraclavicular fossa, there is no palpable swelling, and systemic examination was normal. My probable diagnosis would be phylloids tumor of the right breast with lipoma of the right axilla.
Regarding certain
go back.
clinical signs, you said the nipple areola on the right side is normal compared to the left side.
No,
A large tumor like this, we expect the nipple to be flattened and the areola to be stretched.
Yes.
Are you sure that they are equal in size on both sides and the nipple is normal as on the left side?
Yes, sir.
Can we have a limit?
Yeah.
Dr. Rajshekar, any questions as far as examination is concerned? I think Riya, you have presented this well so far. But Dr. Ashik, sir?
Presentation was good. My doubt is whether the swelling in the axilla that she's talking about, is it a axillary tail which is prominent? She says it's soft and a lipoma. And then she says no swellings in the axilla. You mean axillary lymph nodes, right?
Yes, sir.
Okay.
That can be actually lipomatosis.
Lymph nodes in the axilla and supraclavicular fossa.
Can that be axillary lipomatosis or what we call as accessory breast?
Yeah.
It is axillary breast, please. That is
Yes.
the exact thing. This is pathology in the main breast, but that breast had an axillary breast also.
If I interrupt, even the left side, there's a fullness in the left axilla. If you can see, there's a fat lobe. That
Correct.
picture
There is.
shows it. Come back to the picture. It shows that left side, see, there's a fullness in the axilla below it. The similarly like this. Yeah,
Ravi,
that
sir,
Yeah, yes, sir.
Ravi, can I make a comment? She's postmenopausal, right?
Yes.
Yes.
So postmenopausal, a huge lump in the breast. Why isn't the first diagnosis carcinoma?
Riya, you want to take that question?
Yes, sir.
Yeah.
So, because from her history, on clinical examination, it went towards the benign condition, sir.
What is the
Why?
meaning?
Why? Because it's rapidly progressing. It is over a period of 6 months. It has grown to this size. Why is it going in favor of benign?
Moreover, postmenopausal.
Yes, the swelling on palpation is smooth, sir, and it's lobulated. Sir, it is lobulated, but on palpation it is firm in consistency, sir. It's not hard, and there are no palpable lymph nodes.
Can I make the question a little better?
Yes,
Yes,
sir.
sir.
Yeah. Riya, the question refers to what are the signs which are missing in this case, which will indicate carcinoma? That is the question.
Yeah.
Presence of skin changes, sir.
Correct.
Yeah, tell. What will happen to the nipple? What will happen to the skin
Involvement,
changes?
retraction of the nipple,
Right?
presence of pudy orange,
Yes,
then presence of satellite nodules,
yes.
and
What
presence
will
of
happen to the skin? Skin gets fixed or skin is free?
skin will be fixed. Skin will be
Yeah.
fixed, sir.
So those signs are missing here, isn't it?
Yes, sir.
See, that is what Riya, you should say for a lump of this size, which has progressed so rapidly, I would expect it to be fixed to the chest wall, fixed to the skin, and probably I would have also expected axillary lymphadenopathy.
Axillary lymph. Yes, sir.
So these are the reasons why I would think it is a cystadenoma rather than a carcinoma. I don't
sir.
think Dr. Srivatsa thinks that it is a carcinoma, but he wants you to know what are the reasons why you made the diagnosis.
Exactly.
Yes,
Dr. Ashik, sir?
Yeah, exactly. The absence, all the signs that you just mentioned, that's what sir wanted as an answer. Why you
Yes.
diagnosed it as Phyllodes tumor first,
Okay, sir.
as your first diagnosis.
Because postmenopausal age, Phyllodes tumor are less common.
Correct.
Okay.
Yes. Okay, sir.
Second thing is you must say it is sarcoma. You would say it is sarcoma rather than phylloids. Sarcoma would be a malignant variety.
Yes, sir.
6 months rapid growth is a malignant, indication of malignancy. So likely to be sarcoma.
Dr. Riya, you mentioned about the ECOG and the Karnofsky.
Yes, sir.
And you told us there is a 90 and a 0.
Yes, sir.
Unless you are sure, don't mention it because somebody is going to ask you what is Karnofsky 90 and what is ECOG 0.
Okay, sir.
Can you enlighten us on that?
Use only one scale, please. Anyone.
Okay, sir. ECOG would be 0 would be a patient who is fully active and able to carry out all her daily activities in the pre-disease stage without any restrictions, sir.
So I think the general rule of the thumb is that ECOG is usually referring to patients with malignancy. Karnofsky is for patients with benign diseases. I think
Yes,
that
sir.
is a general understanding. So as Dr. Rajan,
Ravi, Karnofsky score is more for pre-op, right?
no, yeah, but it is usually Karnofsky score is generally applied to patients with the benign condition. ECOG is generally for the malignancy.
No, Ravi, it is used. Karnofsky is used for malignancy also.
Sir, that's not the
And
point
European.
here. The larger point here is don't invite questions.
Yes. You just say one and say.
Invite questions.
Now, again, let's not break and split hairs in front of students.
Yeah.
There are two, both can be used either way.
Right.
Thank you.
I have a question to Riya.
Yes, sir.
Yes, sir.
Can this tumor ulcerate?
Yes, sir.
And how this ulcer differs from malignant ulcer?
Sir, this tumor, when it ulcerates, it is not fixed to the tumor, sir. It's mobile independently.
Mobile with?
Not complete. Answer is not correct. You're there, but you have to be better.
You can improve it.
Improve on it.
The base.
How is the edge of the ulcer? In phylloids, if it ulcerates, where it ulcerates, and how is the edge of the ulcer? Edge.
Sir, in phylloids, the tumor ulcerates at the point of maximum pressure. Sir, there is pressure necrosis.
Yeah.
Normally it ulcerates at the bottom.
Central.
At the bottom. Okay.
Wait.
Yes,
okay.
sir.
And how is the edge of this ulcer?
Sloping, sir.
Sloping,
No.
healing, you mean? Healing, you mean? Edge of the ulcer is undermined here because it is not fixed. It is by pressure necrosis.
Yes,
so it is
sir.
not infiltration. Whereas malignant ulcer, it infiltrates.
Yes, sir.
Okay, right.
Okay.
Okay. So how would you, if there are no further questions on clinical examination, would you like to summarize your history and examination findings?
Yes, sir.
Yeah, please do.
43-year-old postmenopausal middle-aged woman coming with history of rapid increase in size of the right breast swelling. on inspectory findings,
On examination, there is no inspection. Yeah, on examination.
on examination, it is a large right breast lump which is mobile and
With no
with
fixity.
no fixity to the skin, no palpable axillary lymph nodes or supraclavicular lymph nodes, with the systemic examination being normal.
No. Okay. So what is your diagnosis?
I would like to conclude it as a benign phylloid tumor of the right breast.
Would you still insist on it being benign because Dr. Srivatsa has given you enough indications to say it may be a sarcomatous or carcinosarcomatous transformation?
Yes,
Just
sir.
use phylloid tumor, ma. Please don't use the pathological classification because
Yes, sir.
we still don't know. Just say it's a phylloid tumor for evaluation.
Okay. Yes, sir.
So how would you go about investigating this patient?
Sir, I would like to do a mammogram and
Again, we come back to the same problem. So it's such a huge breast, not possible.
Why do you say that, ma?
okay. Sorry, sir.
The patient will be very uncomfortable.
Yeah, you cannot.
Have
you seen
the students know how mammogram is done?
That's what. Have you seen doing mammography?
Mammogram is done by compression.
Compression
In
the
the
glass
craniocaudal and lateral compression, mediolateral compression. It is very painful. I think a lot of women complain of severe pain after mammography. So you have to be absolutely certain. What is the first principle of medicine? Primum non nocere. So don't cause any harm. So your investigation should lead you to something. So here, with such a large mass, there is no indication for doing a mammogram of that side. If you want to do mammogram of the other side, please justify that.
No, sir, because I'm still thinking that it's a benign tumor.
So there is no indication to doing the mammogram for the other side. Okay. So how do you investigate this lady?
I would go on with the FNAC of the lump, sir, right? Yes, ma'am.
I beg to differ because a true cut, you said there's a true cut is already been done.
You only mentioned is a true
You're
cut.
not looking at your history. You said there is a hyperpigmentation or whatever of a true cut, probably you said.
Yes, sir, that was
which led us to believe that a true cut has been done.
No, sir, it's I made a mistake.
Oh, you're deliberately misleading. Okay.
Okay.
No, but it's good to say you made a mistake. Huh? That's nice.
Fine. Yeah.
That's fine.
Rajan, what would you, Swan?
No, I just want to know what she would do. Would she do any invasive investigation pre-op or not?
Yes, sir. I would do an FNAC, sir, and subject it for histopathological examination.
No, FNAC is not histopathology.
Not histopathology.
Cytological examination.
Yeah.
Okay.
I think you should say true cut needle.
True cut biopsy.
It's huge swelling.
So
and
you should get a true cut.
histological diagnosis, differentiating it from benign, intermediate, and malignant. This is the information that you will get in a phylloid tumor if you do a true cut needle biopsy, and that is the standard investigation.
Venkat, you want to add anything?
Okay.
Definitely, I won't put a FNAC needle in this thing because this is too big a lump. FNAC we do when we are going to do breast conservation, very small lump, not for big lumps.
Yeah. So
secondly, it's too vascular. Phylloides is known by its local vascularity. So I don't think we should stick needle in such big lumps. We have to do a primary surgery for the patient.
And also there will be a lot of cystic areas. So you may get only fluid or jelly-like fluid when you aspirate. So you have to core needle biopsy is better.
Okay. Core needle biopsy.
Core needle biopsy is that you can classify, as I said, benign, intermediate, malignant.
Yes.
Very clearly.
Okay. Right. Core needle biopsy, as all of us have agreed. And then what other investigations would you like to do?
That sonomammogram.
No.
Why? What more information will you get with the sonomammogram?
Sono looks for things that are small and are lost, ma. You don't get characteristics from such big masses. Kindly do not mention it.
Yes.
such large
Yeah.
lumps. Okay.
Okay, so sonomammogram, see, you have to understand that any investigation you ask for, you should have a question that you want it answered. So here there
Yes.
is no question. So no need for any other investigations.
Yes,
Would
sir.
you, any other
Would you look at
investigation?
the axilla, sir? Would you image the axilla to see what that soft swelling is?
Yes,
There
sir.
was a doubt whether it is this or that.
Yeah, I would, I think, definitely.
That yes.
Yeah, that definitely I would. Dr. Mohan, sir, any thoughts?
Ultrasound, if she says, would be more acceptable than the mammogram that was originally said.
Correct.
What do you say, sir, Rajan, sir? An
Sir, I
ultrasound
wouldn't do
would
any
give us-
further
yeah.
investigation on the lump, sir.
Yes.
I would subject that axilla needs
Yeah.
a little clarification. Probably I'll image the axilla area, but
Yes.
not anything more.
Okay.
Would you do metastatic workup like you do for a CA breast?
I would do a PET scan, sir.
Ah,
Wow.
she
Yes,
fell
sir.
for it.
With this diagnosis,
Sorry,
don't say
uh,
PET scan.
Bone
See, the-
God, ma,
Don't say
why?
PET scan with this diagnosis.
sorry, bone
With
scan.
this clinical situation, and you know it does not spread such like breast does. This is the point that we're saying. How do you know your theory? How well are you able to differentiate? How do you become safe to the patient? We are here as examiners to give you the license to practice, and you should be safe. We
Riya,
can't allow you
Yes,
to
sir.
make such mistakes.
correct.
Please.
Unless you want
Maybe
to
a
become a
CT
G-
thorax would have been okay, sir, Dr. Rajan, sir.
Yeah.
Even that is it would
Overkill.
definitely be
But
okay,
at
but
least would be better.
I
Overkill.
think you should do a CT thorax if you have malignant variety as a diagnosis or
That-
true cut.
On the true cut. Yeah, I agree with that. I
But
think
Dr.
Riya,
Srivastava, sir,
yeah,
there's a slide here which says this is benign phylloids. If it is this patient, why would you want to do a metastatic workup?
Not
no,
necessary.
no, that is what he said. He said, if it is a malignant variety, only then. Otherwise,
No,
not.
because there's a slide in front of us which says benign phylloids.
Okay, right. So then there is no need for any further
The
investigation.
only issue here is that you can't evaluate the whole lump in one
Whole lump.
core needle biopsy.
Yeah.
So maybe a CT thorax would have been okay, but not a PET CT scan.
Yeah,
Okay,
no,
see-
definitely
Yeah,
not best.
yeah.
See,
It's a huge tumor. You can have several areas of de-differentiation. One area may be benign, another area may be intermediate, another area may be malignant.
That is why I say not necessary to do. We need formal histopathology to know the true histological status of this tumor.
see, Riya, unless you want to become a GP, don't ever say PET CT. Okay.
Yes. Yes.
That's on a lighter note. Okay. Now, how would you manage this patient? How would you treat this patient rather? You've already managed,
Yes, sir.
investigated. How would you treat?
I would like to
One
go ahead.
question, Riya, one question.
Yes, sir.
How would you counsel this patient before you treat this patient?
I was going to come to that. Good that you asked that question. Very good.
Good question.
Good question.
What is your counseling, ma?
Sir, I would like to tell the patient that she will have. I plan she after surgery. I will be planning for surgery, sir. So after surgery, the lump might recur.
No. First
No,
is
no.
talk
No.
about the surgery. What
Will you
surgery?
do? What will you do?
First
will
is
it-
what
Wide
you
loop.
are going to do. What is your plan in your mind? What you're going to do? What are the alternatives available? And what if you don't do? That is how you get a proper informed consent and counseling. Then subsequent to your surgery, what all you plan to do. So please be careful on what you say.
Yes, sir.
Yeah.
I would tell her that I would be planning for a simple mastectomy, sir.
Okay.
And
You say removal of the whole breast. Okay.
yes, sir.
How will you
Yeah.
close?
Remove the whole breast. Yeah. See the students, please understand informed consent has to be very clear, succinct, and in patient's own language so that there is no ambiguity and they understand what you are saying very clearly. And it is probably done with the relative in place. And if you have to repeat yourself several times, please do so, because there should be absolutely no doubt about what you are going to do. Okay, right. Carry on, ma'am.
Any surgery, always you should think how you close the wound.
Yes. Yes.
Yeah, she is a woman. She would like to know whether nipple areola is going to be saved or not.
No, sir. I would tell her that.
Why not?
Why not? It's benign. You can save breast tissue and the nipple areolar complex. You can just do an enucleation. This is for argument's sake, not in this case, but for argument's sake.
In case of enucleation, sir.
What is the margin needed in benign phylloids tumor?
1 centimeter, sir.
2 centimeter around, all around, which is even much more than what you do in breast cancer.
One.
It's a huge lump, madam, not a small lump. It's a very huge lump. You don't want recurrence.
Okay, sir.
Okay. So when you do that, your nipple areolar complex cannot be saved.
Yes, sir.
See, another thing which I have noticed with Riya, and this is to the attention of all the students, please do not repeat the question, because if you keep on repeating the question, examiner will get annoyed. Your purpose is to pass the exam, so keep the examiner sweet. Do not keep on repeating the question so it annoy the examiner. Okay, carry on.
Okay.
Students must know why you are taking that wide margin.
Yeah.
You know, doctor?
Venkat, please highlight, enlighten us.
Yeah,
See, the problem is that phylloids tumor, it can spread along the tissue planes, along the ligaments, compared to malignancy, which can mainly spread along the ducts. So even a 1 millimeter margin or a ink 1 cell margin also may be okay in breast cancer. A focal DCIS on the surface, only focal, single focus, may be okay in breast conservation surgery. But in phylloids, the disease can come back later, even at 2 centimeter margins. So you have to take a good margin so that it doesn't recur. Anyway, you are going to reconstruct this.
Okay.
Venkat, can I also add that
Yes, sir.
phylloids surgery is the primary modality. There is no chemotherapy.
Correct.
Whereas in
Correct.
carcinoma breast, you can fall back on chemotherapy and
Radiation also.
Correct. Yes,
Yes,
agree.
yes. Good
Very
point.
good point, Dr. Srivatsa. Very good point.
PG students must know that any amount of compromising, additional treatment like adjuvant chemotherapy radiation will not compromise for your inadequate surgery. It will not compensate for your compromised surgery.
Okay. So the margins have to be 2 centimeters or more if it permits. So that is the take home message, as opposed to a malignant tumor where you can get away with a smaller margin as long as you are sure about it. Okay.
What is the long-term complication of a surgery, ma, for this? You've done surgery, you've either mastectomy or excision. What do you follow up for? Yes, recurrence. You always send them with a warning that it can recur and to come back early, so that again we can do adequate clearance. But that is phylloides tumors are known for their local recurrence. They're terribly troublesome to the patient, and because they don't have pain, they come late with recurrence also. So
huge breast is removed. Some form of reconstruction, I think, has to be thought of. When you reconstruct with some form of flaps, then there may be recurrence under the flap, which is difficult to examine clinically. So patient must come regularly.
So, and as Venkat has suggested before, recurrences are imaged with the MR rather than a MR scan. MR scan is a better investigation for recurrences. Dr. Rajshekar Mohan sir, anything to add?
Now, when you're taking consent, you probably would have to tell the patient that we are operating thinking it's benign, and our histopathology might turn out to be sarcoma, a malignant form of malignancy. That we would need to tell the patient, in which case we may need to give some form of additional treatment.
Yeah.
That we would need to tell. This is regarding Dr. Godisar's question on taking consent.
Correct.
One of the problems that you can face is the FNAC says benign, but you operate, you find a totally different report. So that we need to tell them there's a possibility, and there might be a need for revision. Second, coming to Dr. Venkatachala's comment about reconstruction, when do we plan this reconstruction? Are we going to offer it upfront? And if not, we need to tell the reason why we wouldn't want to offer it upfront and wait for a report and then plan reconstruction.
Correct. I think all of these points have to be taken into
If
consideration.
I can add, any patient would cause socially and psychologically, it will be good to reconstruct it immediately, because we can understand the problems associated, social problems associated in India after mastectomy. So if you reconstruct immediately, the risk is that local recurrence may not be easy to detect. So you'll have to do MRI scans to detect. The only problem is if you delay the reconstruction, means at around 1 year, 1.5 years, we have seen that most patients will refuse a reconstruction. They are happy with the whatever mutilation or whatever you want to call the defect. They are happy with that. So it's very not easy to convince them later.
Venkat, I thought, I don't think Indians are that particular about reconstruction straight away.
No, they won't be, but you have to, as a doctor, you know that it is correct. So you have to put it to them. If they agree, it is okay.
Dr. Godhi sir, what's your view on that?
Yeah, reconstruction, most of the patients are happy with an externally worn prosthesis.
Correct.
They devise their own prosthesis and externally wear it, and they are very happy about it. I think reconstruction is not really required in majority of the Indian patients, unless the patient is extremely cosmetically conscious patient.
Wherever we do mastectomies, we offer them straight away reconstruction.
Yeah,
Ravi,
that is, yeah.
Ravi, can I make a few
Yes, sir.
general comments because
Yes,
two
sir.
breasts were presented? Number one is the history of OCP versus HRT. You know, HRT contains more estrogen, and OCP now has been modified, keeping the risk factor in mind. They have reduced the estrogen content of OCP and increased the progesterone content. Hence, HRT is more risky than OCP consumption. And the
Correct,
second
sir.
thing
You are right,
is,
sir.
when you go into the family history of breast cancer alone is not enough. They must ask whether there's a family history of ovarian cancer,
Endometrial
family history
cancer.
of colonic cancer, family history of thyroid cancer, looking at Cowden syndrome,
Blood
Kendall
cancer also,
Cronkite
sir.
syndrome, etc.
P53 mutations, blood cancer, sarcoma, brain tumors also.
Yeah. And thirdly, when they examine the patient, inspection is done in the sitting position. First, they examine the normal breast on inspection and compare it with inspectory findings of the involved breast. On palpation, they do it in the semi-recumbent position. They palpate the affected breast first, and then they palpate the opposite breast. And thirdly, when you look at investigations for LABC, you must ask for a CT scan of the abdomen and chest, than ultrasound scan and chest X-ray. It is now the standard of care for LABC as far as investigation is concerned.
Yeah, I think.
Right, sir. I would like to add, Ravi, the internal mammary nodes, mediastinal nodes are not picked up on chest X-ray.
Precisely,
Lung, also plain CT thorax is far more better than a X-ray chest.
That was my point earlier. I think Dr. Godhi made a very good point. I think, examination, as Dr. Srivatsa has very in detail, enunciated, it is important to examine in that order. But as Dr. Godhi said, mentioned that the other breast is normal on clinical examination, and then go to examination of the affected breast, so that there is no confusion. You can't keep on flitting from one side to another. You finish, you can examine the patient in the order Dr. Srivatsa has mentioned, but when you present it, you say that the left breast is clinically normal, as is the axilla. Now coming to the examination of the right breast, so that everybody is clear as to which you are presenting. Dr. Godhi sir?
I agree with that. One more question regarding the management of this particular case. Such a huge tumor, and skin is stretched out and thinned out. If you really want to do the wide excision with a wide margin of 2 centimeters, will you be able to primarily close the defect in this particular case is my question.
Riya?
Yes, sir.
Did you understand the question?
Yes, sir.
What is your answer?
Sir, flap reconstruction, sir. DIEP or tram flap can be used, sir.
Yeah, this
What is
is
DIEP?
counseling. This
What is
counseling-
close to the breast? What is the muscle which is closer to the breast?
Latissimus dorsi.
Latissimus.
Yeah,
Yeah.
simple flap, latissimus dorsi first, local flap first, reconstructive with other flap. What is DIEP?
Deep inferior epigastric perforator.
Artery, deep inferior epigastric artery, perforator flap.
Flap. Yeah.
See, LD flap, wherever you use, you can use it, but always you need an implant. You need to put an implant because this is benign. You can get away with an implant and LD flap. Otherwise, a tram flap will give very good cosmesis, or a DIEP flap, TFL or tensor fascial at a microvascular flap. All these can be used.
Okay.
This point needs to be included in the counseling notes.
Yes.
Yes.
Lastly,
How are we doing with
Shankar?
time?
Yes, sir.
Ravi Shankar, only one point lastly.
Yes, sir.
Anterior chemotherapy or neoadjuvant chemotherapy, the most important advantage is you can definitely see the response to chemotherapy. The tumor response to chemotherapy is predicted on anti-chemotherapy. Very important advantage. And second thing is it does not alter the overall survival or relapse-free survival of a cancer breast.
Yes, sir.
It is
Ravi
mainly
Shankar,
for breast conservation with the intent of breast conservation or in the presence of LABC that it is given to
Okay.
downsize the tumor.
So,
Agreed.
Dr. Rajan, do you want to summarize?
summarize.
No, again, we are going into controversy. Please, I'm
Please
telling you.
summarize, sir. Please
That's
summarize.
why I
Somebody
said,
has a question,
Dr. Rajan,
PGs?
please summarize. PG.
Sir,
Yeah.
I think the student has a question.
Yeah, please.
Yeah. Yes, sir. Because the patient has a high rate of recurrence post-surgery, sir. I wanted to know, so how long to follow? How do we follow up the patient, sir?
Every 6 months, ma.
Every
Clinical
6 months
examination.
initially,
Clinical
For
and
how
after
long?
2 or 3 years, yearly once.
Year, up to 2 or 3 or 6
At
months.
least 5 years. At least 5 years.
No, better follow them lifelong because once they had a lesion, it is annual health checkup. It will be like an annual health
Yeah.
checkup. That not be a problem. They will come.
It is
But-
lifelong.
Yeah,
Lifelong.
because once if you do a reconstruction, it should be more close follow up. Means they have to come regularly.
Yes, sir. Sir, and about the opposite breast, sir.
Yeah.
Nothing. Just follow up. Nothing.
Follow up
Yes.
with an annual mammogram just for like a usual breast cancer patient, general population, not like a phylloid tumor to come back on that side.
Okay,
Dr.
sir.
Rajan, please summarize,
sir.
sum up.
Nothing.
Dr.
This is two things. One is the candidate has presented it very well, and you are a definite pass for this kind of performance. Well done, doctor. The
Thank you, sir.
discussion is a little tricky. You have to be available for all types of questions. Dr. Srivatsa has given us a very good summary of how you would examine a breast inspection, palpation, palpation. So affected side, non-affected side, and everything should be all information gained and then presented in a single way of the affected side, normal side first, being normal, and then the findings of the affected side. Diagnosis should be clinical, staging should be clinical, and workup should be towards confirming diagnosis and metastatic workups. In benign disease, the surgery tends to be a little bit more conservative, and on final histology, you will have to decide on the further management if it turns out to be phylloides sarcoma phylloides.
If I like to add, sir, both the PGs presented very well actually. But the thing is that they have already made a PPT and they are presenting this exam. In the exams, you are given only 20 or 25, 30 minutes to prepare. So they must be very clear with their concepts.
Yeah.
And the practice to present without seeing.
Yeah, Venkat, I think Dr. Krishna Kumari, if you are there, and Dr. Riya, you can see the compare and contrast between the two. Both of you presented well, I agree. But Dr. Krishna Kumari, you put in certain things like open biopsy, incisional biopsy, those kind of things you should avoid because it gives a wrong impression about how much you know and what are the indications for each of these.
Okay.
Yeah. Thank you, sir. Thank you, Dr. Riya. We'll move on to the next case. Dr. Ashik Aslam.
Yes, sir. Good evening, sir.
Yes, you have 45 minutes, Ashik.
Yes, sir. Thank you, sir.
There is echo. There is echo with your presentation.
There may be some mobile or something or some other mic or something.
Yes, please unmute others mobile. Sorry, mute other mobile.
Sir, how is it now?
Yeah, now it's clear. Now it's clear, Ashik. Please, please proceed.
Good evening, respected teachers. Today I am presenting a case of inguinal hernia. Here is a patient, Mr. X, with 52-year-old male who is hailing from Kanakpura, Bangalore, who has studied till SSLC and a plywood factory worker by occupation. Chief complaints, complaints of swelling in the right groin since 5 months and complaints of pain over the right groin since 4 months. History of presenting illness, patient was apparently normal 5 months back. Then he noticed a swelling in the right groin since 5 months, which was insidious in onset and gradually progressive to the present size of approximately 4 into 3 centimeter. Swelling first appeared on straining and now increases in size on standing, walking, and doing strenuous exercises. The swelling completely disappears on lying down on its own, and there is no complaints of any swelling in the opposite side. Patient also complains of pain in the right groin since 4 months. It is dull aching in type and aggravates on straining and relieves on lying down. There is no radiation of pain. There is no history of nausea, vomiting, constipation, or abdominal distension. There is no history of chronic cough or breathlessness. There is no history of difficulty in micturition, urgency, or increased frequency of micturition. There is no history of hesitancy or dribbling of urine, and there is no history of any acute retention of urine. And there is no history of similar swelling on the other side. Past history is known case of type 2 diabetes mellitus who is taken on treatment. No history of hypertension, asthma, COPD, or tuberculosis in the past. No history of similar complaints in the past. No history of any abdominal or groin surgeries. Drug history, he takes tab glimepiride 1 mg plus metformin 500 mg BD since past 1 year for diabetes, and there is no history of any drug allergy. Family history, there is no significant family history. Personal history, patient has a mixed diet with good appetite, sleep is undisturbed, bowel and bladder movements are normal, no history of any smoking or alcohol consumption. Coming to the summary of the history, 58-year-old gentleman, laborer by occupation, who is a known diabetic, presented with reducible swelling and dull aching pain in the right groin since 5 months, which aggravates on doing strenuous activities with no history of vomiting, constipation, abdominal distension, vomiting, or rapid increase in size of the swelling. Shall I continue, sir?
No, some questions, please.
Yes.
You should not start by saying that I am presenting a case of inguinal hernia.
Okay.
No, there ends the matter, if you say that, isn't it?
Yes.
Otherwise, the history is complete.
No, other thing, one more thing, you are saying that size is about 3 to 5 centimeters. You say it is reducible. How can be so sure of the size? That is not in inguinal hernia. The size is variable. That is one. Did you elicit the history of patients self-pushing or self-reducing? Because it's the rates doing work and all. Did you mention about that?
Yes, sir. The swelling reduces once the patient lies down, sir, on its own.
Doctor, you mentioned about a history of some abdominal surgeries. What are you interested in?
Sir, any previous abdominal surgeries like appendicitis or can cause injury to the nerves of the groin region, which can cause the weakness of the groin region that can lead to
which nerve?
Hernia, sir.
Which nerve?
Hypogastric nerve, sir.
What does it supply?
Lower abdominal muscles.
You must be more specific. You can't say lower abdominal muscles.
Sir,
which surgery specifically? Previously it used to be a very popular and common incision.
Lumbar sympathectomy and surgeries for removal of stones, ureteric stones.
For appendicectomy, they used to do a procedure through that incision called battle incision. Do you know anything about it?
No, sir.
So it is actually a battle incision used to be made for appendicectomy. It used to give fantastic exposure, but later they found that a lot of these patients started, presenting with post-operative hernia, inguinal hernia. So
I
then
think you
they
need to
stopped.
tell them what is a battle, sir. I don't think they've read or seen a battle.
There is a battle in their mind now.
Yes.
Rutherford Morrison incision.
No, battle is a different one.
Battle is different. Rutherford Morrison, another incision.
Extending to the right lumbar region.
So it used to damage the ilioinguinal and iliohypogastric nerves, which is why they would develop hernia at a later date. It is the weakness of the oblique muscles. So that is the reason why that particular procedure was stopped.
Please tell what is battle incision?
The battle incision is actually, it is a transverse incision, and there you don't actually cut the muscle.
Paramedian incision, please.
Lateral paramedian. It's a lateral paramedian incision.
It's a pararectal incision.
And it would not cut the muscle, but still it would injure the nerves, which is why it is stopped. But it would provide excellent access to appendix.
We used to see earlier. We used to see a lot of these incisions. I don't think it is practiced now.
Yeah.
No, it's not practiced, and it shouldn't be asked for nowadays.
Yes.
Sir, Dr. Godi, sir.
Can you move on, please?
Yeah, I just want one clarification. Even Dr. Rajan or Dr. Godi, sir, with respect to all these so-called, the chronic obstructive airway disease, chronic cough, urinary symptoms, and chronic constipation, they are relevant, of course, because the problems may bring a hernia to the fore. So the problem needs to be addressed, whether it is form of enlarged prostate or a sigmoid malignancy or stricture or even chronic obstructive airway disease. But do they have any bearing on the the formation or the of the hernia?
They do have a bearing on the formation of the hernia. More than that, they can recur. The hernia after repair can recur if you don't attend to these complaints of the patients, like urinary complaints or chronic obstructive disease and chronic constipation. They can come back with recurrence. That's the importance here.
Yeah, absolutely. Dr.
Also,
Rajan?
They should be telling that if you don't tell, you'll ask why you didn't tell. So it says this thing system should be continued.
Yeah. So I think the current teaching is that the hernia happens because of the defective production of the collagen, type 1, type 5 collagen. So probably the formation of hernia may not have much to do with all these symptoms, but as Dr. Godi said, if you don't address the problem, they are bound to recur because the problem persists. So you need to address the problem, and sometimes the hernia is the least of his problem. If at all there is a sigmoid or a rectosigmoid growth, which has brought this to the notice. In that case, you are addressing the rectosigmoid growth, and hernia can be taken care of at a later date. And chronic obstructive airway disease, again, a proper evaluation and treatment may help the patient become less symptomatic and improve the quality of life. Okay. So
the word for that is called the decoy hernia, where the hernia is the presenting symptom, hiding a deeper pathology inside.
Absolutely.
So
Absolutely.
it should be necessary. And
Correct.
when you have other pathologies, the weaker collagens give way easier. That
Correct.
is the connection between the two. Can
Correct.
we move on, please?
Yes. Please move on to the clinical examination. If there are no questions about history. Yeah. Okay.
Coming to the general physical examination, sir. Patient consent was taken prior to examination. 52-year-old male patient who is conscious, cooperative, and well-oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema. Vitals, pulse rate is 76 beats per minute, measured in right radial artery in sitting position, normal rate and rhythm, volume, and character. BP is 130 by 70 millimeter of mercury, taken measured in the right arm in sitting position. Respiratory rate is 16 cycles per minute, and his BMI is 21.77 kilogram per meter square. Local examination, patient was examined in a well-lit room in standing position, exposing from xiphoid process till mid-thigh. Inspection, a solitary globular swelling measuring approximately 4 into 3 centimeter in the right groin, medial to the mid-inguinal point, extending up to the root of the scrotum. The swelling appears smooth with rounded margin. Skin over the swelling is normal. There is no scars or sinuses. Swelling is expansile on coughing. Swelling reduces on lying down on its own. No visible peristalsis seen. No deviation of penis. Bilateral testes are seen separately from the swelling and appears normal. Palpation, there is no local rise of temperature. Tenderness is present over the swelling. All inspectory findings are confirmed. A globular swelling measuring 4.5 centimeter into 3 centimeter is felt in the right inguinal region, extending from 1 centimeter above the mid-inguinal point to the pubic tubercle. The swelling is soft and elastic in consistency. The swelling reduces spontaneously on lying down, and testis is felt separately. Coming to Siemens test, the impulse is felt in the middle finger. Ring occlusion test, swelling appears medial to the occluded finger. Ring invagination test, the superficial ring is lax and an impulse is felt on the superficial inguinal ring with the pulp of the finger, and the finger goes directly backwards. A percussion, the patient is examined in standing position, a resonant note is heard, and auscultation, bowel sounds are heard. Opposite inguinal region is normal. There is no swelling noted in the left inguinal region. There is no expansile impulse on cough on the left inguinal region. Abdominal muscle tone is good and there is no bulge seen. Examination of the external genitalia, scrotum, the skin appears normal. Testes, both testes are normal and separately palpable. Spermatic cord is normal on both sides. Penis, normal in position, no deviation. Meatus is normal, no discharge or stenosis. Urethra is normal. And inguinal lymph nodes, no enlarged inguinal lymph nodes. Per rectal examination, no fissures or sentinel piles. Anal tone is normal, no mass per rectum, and prostate is normal. Systemic examination, cardiovascular system, S1, S2 is heard, no audible murmurs. Respiratory system, bilateral, normal, vesicular breath sounds is heard, there is no added sounds. Per abdomen, abdomen is soft, non-tender, no guarding or rigidity, no organomegaly or palpable mass. Coming to central nervous system examination, he is conscious and oriented. There is no focal neurological deficit.
Okay.
Right. Give you a summary, please.
So here is a 52-year-old male, non-diabetic, with complaints of pain and swelling in right groin since 5 months. It's a reducible swelling in the inguinal region with an expansile cough impulse seen above the inguinal ligament with smooth surface extending till the root of the scrotum. Swelling is tender and elastic in consistency. In ring occlusion test, swelling appears medial to the occluded finger.
Okay, so there is questions about the finger invagination test. I think I would like to invite comments from Professor Godhi and Dr. Rajan, but I think it is a test mentioned to be condemned. I don't think you should do it because it is painful to the patient. You are not going to get any extra information. So I don't think it is to be mentioned at all. The ring occlusion test is all that you need to do because that will give you all the information that you need. Dr. Godhi, sir?
I agree with you, Dr. Ravi Shankar. Completely agree with you. The imagination test is painful, so it doesn't really add to the information. And they should know what is the principle there. They need not do it actually.
Yeah. So if the examiner asks you, you can mention, sir, I did not do it, but the principle is this. So as long as you know what it is about. Dr. Rajan, sir, do you want to add anything? Dr. Rajshekar, sir?
I agree with Gauri. We expect you to know the reason for doing it. That's all, and how you interpret it. Yeah. That's all. You don't have to do it.
Okay. What's your diagnosis?
One last question before that is, how did you check the tone of abdominal muscles, please?
Sir, I asked the patient to raise the head with both arms over the chest, or to raise both legs with knees extended, sir. On examination, there will be bulge over the flanks, sir, lateral.
That is not enough. You have to do just a pure lateral wall muscle contraction, and that is best demonstrated by the Valsalva maneuver. The head raising and the leg raising contracts only the rectus muscles. So,
Rajan sir, will you insist on that test?
I don't insist. If they mention it, I definitely ask how they do it. And
Dr. Ravishankar, you
Yes, sir.
told about the discomfort of the patient. When the patient is allowed to do a PR, then invagination and PR is almost uncomfortable.
I agree, but what extra information are you going to get by doing a
Even
finger
the same thing
invagination?
with PR, no? The symptoms are not there. I don't know.
Precisely.
The question is there any real indication for doing a PR in this patient?
No.
No, sir.
There is no indication. There are no symptoms of indicating a need for a PR examination. There is no need for a PR examination in this patient.
See, previously, even for appendicitis, they said if you don't put your finger in it, you put your foot in it. But I think those dictums are long gone. I think violation of patient's cavity has to be justified by information that you are going to glean. So in that case, I would say even rectal examination is probably redundant. Your point is
please remember, those days there was no investigation.
Correct.
You had to do clinically everything.
Yeah, correct.
Today we have imaging available, and that will give us more information. So invading into the patient for clinical information is not necessary when an investigation will give it to you properly. But we should know the interpretation of these signs and reasons why these things are done.
So if
Ravishankar, can I make? Yeah, even Siemens test is redundant.
Yeah, exactly. When there is a bulge, noted bulge, when there is a definite hernia, you don't do a Siemens test. You do it only if there's a doubtful hernia and you're looking for an impulse. But you don't do it when there's a definite hernia.
Yeah. Second thing, practically, I have used invagination test when somebody complains of pain in the groin. There is no swelling. There is no obvious cough impulse. I put a finger and check if there is any cough impulse at all on invagination. Yes. It's a completion of examination to check clinically whether there is any impulse on the tip of the finger at all. Many times you have found that even imaging has gone wrong. I've operated on a patient who insisted that he has got a hernia on the right-hand side based on the ultrasound finding. And I examined and I said no hernia. And I opened, there was no hernia. So I do it only when I do invagination. On clinical examination, no cough impulse found, no swelling. I do the invagination to check and I reassure them.
So this is a special circumstance.
But in the exams, definite cases are kept. So I don't think we should do it.
You don't need to do it. I think that is the take-home message. Actually, if you want to be controversial, differentiation between direct and indirect hernias are also redundant now, because when you are operating, you do look for a sac along the cord structures anyway, whether it is laparoscopic or open, but that is for another day. But the thing is,
again, I will say, yes, it may be redundant, but we are teaching a method.
Correct.
Part of life is to follow a system and follow a procedure, being complete in what you do. If you start skipping clinical steps, they will also skip such steps in their careers. So this is important at this stage that they go according to the order. And
so the ring occlusion test is the only test that is you are expected to do, and you should do it properly. Okay. So what is your diagnosis?
Before that, one question.
Yes, sir.
Now concessions is a ring occlusion test is the most important test. No doubt about it. But when is the ring occlusion test inconclusive, or
you can't make out?
You can't make out. It gives false results. When is the ring occlusion test inconclusive?
Doctor?
Sir, when the
do you know the answer or you don't?
No, sir.
Okay, Dr. Godhi, sir.
Yeah, when the ring is too wide and stretched too wide, then you can occlude it only with a finger, one finger, isn't it? The method is to occlude the ring with one finger. And if the ring is too wide stretched, then the indirect hernia also will pop out in spite of occluding the internal ring with one finger. So it gives a false impression that it is a direct hernia, but actually it is an indirect hernia with a wide internal ring.
Okay. Right. Okay. So come to the diagnosis now.
Sir, it's a right-sided, incomplete, uncomplicated, reducible, direct inguinal hernia with enterocele.
Okay. So
if you say uncomplicated, is there a need to say reducible?
No, sir.
And
But
does it
for
really matter?
Godi sir?
Yeah, it's not necessary to say reducible. Uncomplicated, reducible is uncomplicated only.
Yes.
But this sentence has been taught for such a long time that it is sticking and difficult to replace it.
Dr. Rajshekar, you wanted to say something?
My question to the candidate, does it really matter preoperatively knowing whether it's a direct or an indirect hernia? How does it matter how you're going to manage?
Yes, sir, it matters.
Yes, yeah, please.
Sir, direct hernia is due to the defect in the posterior wall, sir, of the inguinal canal.
How does it matter to the patient? This diagnosis of direct versus indirect, how does it help you in any way? You're going to do the same procedure anyway, isn't it? You're going to operate and you may find what you thought was direct is indirect, etc. happens. So how does it really matter? In what way does it matter? All these tests that we are discussing to differentiate between direct and indirect.
See, for lack of time, do you know the answer or you don't?
No, sir. It doesn't matter.
The reason is that indirect hernias tend to develop complications. So you can actually tell the patient you need to get operated early. Whereas with the direct hernia, you can tell the patient confidently that, yes, you can wait and come at your convenience at your period in time.
Yeah,
that is the advantage that it gives you. Otherwise, it doesn't really help us in any way.
I'm not agreeing from the exam point of view, Dr. Ashik, because you say direct hernia, I want to send the patient home and then you get into trouble. It is safer to say I want to operate.
Okay.
Yeah. As of now, watchful waiting is not for the exams, which is for the practice. So every hernia is supposed to be operated for that potential of complications. In the discussion, they may find out if they ask for other points.
The students, please note that
point is
what Dr. Raj.
Is,
yes, sir.
The point is, if the patient is old patient, let's say a senile patient of 75 has come with a direct hernia, which is completely asymptomatic, do you want to still operate? There is no need for operation for such a case.
Yeah, I think it is case by case. So the students, please note that hernia is one of the prototype clinical cases that is kept in the examination, and to follow a prescribed method of history taking clinical examination is desirable, and that is what is expected of you. Controversies can come later, but I think the important thing is you should be able to clinically distinguish between direct and indirect hernia and present it in the examination. You can be wrong, but so can be the examiner, so you don't have to worry. But the important thing is you should be able to clinically make out whether it is a direct or an indirect hernia, apart from the various exclusions that can happen in both situations. Yeah.
Ravi Shankar?
Yes, sir.
Now there is a European Society's classification of hernia, which is very practical.
Yes.
One, they say medial or lateral. Medial is direct, lateral is indirect. Then second thing is primary or secondary. That secondary is recurrent.
Yes.
Primary is the first presentation. And thirdly, they look at the size of the ring.
Yes.
And the size of the ring is measured by the breadth of the index finger. So it is about 2 centimeters, 2.5 centimeter breadth. 1 finger, 2 finger, 3 finger. So they make the classification according to this. Okay, medial, lateral, M or L, P or S, and 1, 2, 3.
Yes, this is
so
for
that
gold.
is a very easy method of practically classifying inguinal hernia.
Yes, very good. Dr.
Given
Srivatsa,
in Balian law.
This is
and
for
also
gold
it is a post-operative classification. It's not a clinical classification, please, because we make mistakes clinically. It is after operative findings, you give it the correct staging and the correct method in the EHS method.
Okay, right. Now, how will you investigate this, gentleman, and what would you like to do, doctor?
Sir, I would like to do basic blood investigations. Along with that, a chest X-ray of the patient, and then ECG and ECG of the patient, and then
why ECG? Why ECG?
So he's a 52-year-old male, sir. According to the due to age, sir, I would like to do a.
It's not about age, man. I agree that you need to do an ECG, but why? You said something about his comorbidity.
So he's a non-diabetic, sir.
Correct. So he could have had.
He can have silent
ischemia. So
Yes.
you need to assess, because post-operative morbidity and mortality may be due to that. So you have to evaluate that. So he's a diabetic, so you do need to do an ECG. Correct.
Yes, sir.
But you should know why you do these things. That is the important thing. Yeah. Carry on.
Control his blood sugar levels before surgery. USG ultrasonogram of inguinal regions.
Why do you need to do that?
Abdomen.
Abdomen, I agree, but why do you need to do inguinal region? Is an inguinal hernia a clinical diagnosis or an ultrasound diagnosis?
Clinical diagnosis.
So when do we do an ultrasound, for example? Let us say a patient comes to you.
Yes, sir.
Yeah. When do you do an ultrasound examination of the groin?
Sir, when patient complains only of pain,
correct.
And,
there is no obvious swelling.
Yes.
If there is no obvious clinically detectable hernia, and
Yes,
if the patient complains of groin pain or dragging sensation in the testes or in the groin or in the inguinal region, then you can do an ultrasound scan, but not when there is an obvious lump like this.
Yes.
Dr. Rajan, sir?
There's only one indication, and that's the insurance purposes. The insurance will negate a claim for on clinical diagnosis. You have to have some investigation to show that there was an inguinal hernia. So unfortunately, we are being pushed by insurance.
That's fine, but clinically,
clinically not necessary.
Not necessary.
Also, sir, it may detect it the other side. That is also important. You have to the other side, which is not seen clinically.
Yeah.
Yes.
Yeah, agree.
Okay.
If the patient has some urinary complaints, post-void residual urine.
Yes.
Post-void residual urine is another estimation which is easily done by ultrasound.
Absolutely. And
Okay,
that is,
now,
yeah.
Ravi Shankar.
Yes, sir.
See, this is given in Bailey law, so I'm just saying it. As it was mentioned, opposite side,
Yeah.
20% chance of getting a hernia.
Yeah.
And ipsilateral side, there is no need for an ultrasound for diagnosis.
Correct.
Unless there is a confusion in the diagnosis.
Correct.
Somebody wants to differentiate a difficult case of a hydrocele from a hernia, hydrocele extending towards the groin.
Yes.
So there is a confusion in the diagnosis. You go for investigation.
Correct. Correct.
There is a complicated hernia, irreducible, huge hernia, or a reducible, a sliding variety. You want to know the content.
Yes.
Yeah.
Yeah.
But again, I think sliding hernia is, as Dr. Rajan said very clearly, even a pantaloon hernia or a sliding hernia is an operative diagnosis rather than a
clinical diagnosis.
Clinical diagnosis. Though you may get a clue, if the hernia is not fully reducible, then you may suspect that it may be a sliding hernia.
Yes, content.
Yeah.
Good evening,
Yeah.
sir. This is
Can we
Dr.
move
Anil.
on, please?
Yeah, move on.
One last question.
Yeah.
So always at this point of time, the examiner always asks, give me the differential diagnosis for an inguinal hernia. Many students are stuck here because there are so many. Just for our sake, tell us the complete elaborate way of answering this question.
That is a tricky one in the sense, what is the level at which you go at exam? You can start with the skin. It can be a sebaceous cyst to a subcutaneous thing like a lipoma to a deeper level lesion like an inguinal hernia, encysted hydrocele of the cord, femoral area, saphina varix, femoral hernia, and in the hernias also whether it's a direct or an indirect hernia. And lastly, if it is the lymph nodes. These are the ones that come up in the differential diagnosis. Depends on how they want it. Essentially, we have to differentiate between femoral hernia and inguinal hernia. And in inguinal hernia, direct or indirect is the one. The one thing that comes as the swelling in that area, which can mimic some of the findings, is an encysted hydrocele of the cord.
Dr. Godi and then Dr. Rajshekar.
In a lean patient, I don't think at the postgraduate level they should consider all these possibilities. These possibilities come only when the patient is 110, 120 kg, obese patient, and there's a lot of fat in the area, in the groin, in the thighs. It's difficult to conclude what it is, what you see. In such patients, you will have to consider the differential diagnosis. In a lean patient like this, the one which is presented here, I don't think they should consider all these differential diagnoses. But then in the undergraduate level, yes, they would like to mention all these things. But postgraduate level are different from the undergraduate level.
Correct. Dr. Rajshekar sir?
PG level, no need except in that situation, Dr. Godi says. UG, yes, we can accept it. But for this level of discussion, we don't need to have a differential diagnosis.
I think even UG level, if there is reducibility and cough impulse, no differential diagnosis.
Correct. See, the overriding theme of this, the teaching session yesterday and today is that if something is very obvious, you don't necessarily need to give a differential diagnosis. If there is confusion, if there is doubt, then you can give the differential diagnosis in the order of preference that you think it is likely to be. So I think the student should please understand that. Okay, now going to the management of this patient. What would you do, doctor?
Sir,
counsel the patient first for me. What would you tell the patient? What? Yeah.
Sir, I'll counsel the patient to get operated, sir. We will plan for a Lichtenstein, open Lichtenstein, tension-free mesh repairs.
Why would you operate on this patient at all in the first place?
So he is having pain, sir, and he is a laborer by occupation, and the swelling is increasing in size.
Correct. So it is symptomatic hernia, and it is likely to cause him trouble because he is likely to lift heavy weight, and there is potential for obstruction and strangulation.
Yes. Can you lift heavy weight after surgery? Can this man be allowed to lift heavy weights after your whatever types of surgeries you do?
Doctor?
After 3 months, we can allow the patient.
15 days after mesh repairs, you can do all the
teaching, man. See, those 3 months was for tissue repairs when they used to do that.
Correct.
Now, when the mesh is put, there is no tension. That is why it's called tension-free.
Tension.
Okay. So you don't have to give that same. I think they can lift the weight and do yoga and whatever they want to do. 15
as
days
long as they are pain-free, they can resume all the activities.
Normal. Dr. Rajshekar sir, what is your advice?
Same, I agree with Dr. Rajan sir. 2 weeks would be sufficient, 2 or 3 weeks. In the earlier days, we used to actually advise this 3 months period of not lifting weights, etc. But this is fine. 2 weeks should be sufficient enough recovery time.
Okay, so you said Lichtenstein repair. So the patient says, what is this new laser operation that they do? Would you like to consider me for that? So what would you say to the patient?
So laparoscopic surgery, sir.
Yeah. Would you offer it to this patient?
So if we have the surgical expertise, I will offer this surgery for the patient, sir.
Now this patient has come to you. How would you word this? Would you err on the side of recommending laparoscopic surgery or open surgery? And how would you make the patient, agree to what you want to do?
Sir, I will counsel him for a laparoscopic surgery, sir.
Why? What is the advantage?
Sir, advantage is better reduced post-operative pain and early recovery from surgery. One more thing, sir, we can inspect the opposite side of the hernia, sir. If there is any hernia which was not seen clinically, and we can repair the femoral hernia also at the same sittings if we find it.
Doctor, I'm a little confused with your line of reasoning. When asked first, you said Lichtenstein's.
Yes, sir.
Now, when Ravi Shankar sir asks, you quietly migrate into laparoscopy. You make up your mind.
we have the surgical expertise, sir, because every centers and every
Then you should have told that answer first. Now you are diplomatically changing your stance.
No, he did say depending on expertise. He did say that.
No, he should give from his side first. In the exams, you expect him to talk from his side, right? His skills.
My side, I told, sir, first is
very good. Okay, good.
You said Liechtenstein.
During counseling only, we have to give option. During counseling only, we have to give option. We have this thing. These are the disadvantage. These are the advantage.
Yes.
What you opt for.
Okay.
What is the cost factor, all these things.
So what is the major disadvantage with laparoscopic surgery, doctor?
Disadvantages are nerve injuries.
No, not nerve injuries. Not nerve injuries. What is the major disadvantage?
Sir, recurrent.
Recurrence rates are
equal to open surgeries.
Slightly more, I would say. Slightly more with the laparoscopic surgery.
Okay, sir.
And if you are doing a TAP procedure, any major disadvantage? Potential for?
Incisional.
No. If you are doing a TAP procedure, there is potential for internal visceral organ injuries. Is there not?
Sometimes I think he is confused as to what a TAP is, sir. Dr. Ravi Shankar, sir, I think we need to clarify that. Doctor, do you know what a TAP is?
Sir,
okay. Yeah.
I would put it this way. First is the higher.
Just a minute, sir. We'll just find out what does he know by a TAP.
Yeah. I think Dr. Rajesh is correct. Right, doctor. Yeah.
Transabdominal preperitoneal repairs.
Okay. So, and what is step?
So TEP is totally extraperitoneal repairs.
Okay.
Okay.
So,
Ravi Shankar.
Yes, sir.
Ravi Shankar, I think what everybody is worried about while doing laparoscopic surgery is whatever precautions you take, right? Yeah. There is a chance, some chance of mesh getting infected. That's number one, which does not happen with open surgery. I have done open surgery for donkey's years, no infection of mesh so far, but that exists with laparoscopic surgery. And second thing, no doubt expertise. Third is that there is a chance of vessel or visceral injury. Yes, definitely less than 1%. Yeah. So I think this would be the disadvantages of laparoscopic surgery. And the advantage is what he mentioned again is what he mentioned. Nerve injuries are less common. Neuropathic pain, chronic inguinal hernia are less common.
Yes.
Yeah.
We are left with 5 minutes, sir. Shankar,
okay.
Sir.
Okay. Doctor, please describe the procedure of open inguinal hernia repair.
Sir, the patient is given spinal anesthesia.
Why not general anesthesia?
Sir, for open repairs or any surgeries below umbilicus, regional anesthesia is better than general anesthesia.
Why not?
Okay. Why not local, man? I do all mine
not local.
Local also. Yeah.
I knew sir would ask this question. Why not local?
Local, yes, sir. We can give a local anesthesia also, sir. But then also you have.
Would you know how to give a local anesthesia?
No, that's too much technical.
Okay.
Okay. Spinal.
Sir, Rajan sir, you can highlight how to give local.
Well, there are two forms of local. One is a regional block, and the other is a layer by layer infiltration. I prefer the layer by layer infiltration by giving enough at each layer before I go into the canal.
Okay,
subcutaneous deposition, dermal subcutaneous deposition, open external oblique, further deposition in the canal, wait for some time, and then open cremasteric box and go in. So this way I use about 45 ml of 0.5 xylocaine with adrenaline. And I get perfect anesthesia for the duration of surgery, which is about an hour. Local teaches you to be far more gentle with the tissues, less trauma, and less injury to the patient. And that is why they recover faster. When you're operating and the patient is not feeling, you tend to be too rough with the tissues, and that causes more post-operative pain, is my observation. Thank you.
Okay.
Rajan sir, one question for you, just for the PGs. Do you like to mix short acting versus long acting?
Yes,
local
yes,
anesthesia
yes,
medicine?
Definitely, yeah. You always put a 1/3 amount of long
UPVK.
in it so that you get an immediate post-op analgesia. At the end of the surgery, whatever's remaining in the bowl of local anesthetic taken, I splash it into the wound so that they get some immediate post-operative pain.
So, Rajan sir, at the end of surgery, you can still make some infiltration, right? Local infiltration.
Yeah, of course you can. Of course, yes.
So the other thing is the regional block is to first infiltrate along the pubic tubercle and also in a fan-shaped manner along the anterior superior iliac spine. And then, as what Dr. Rajan said, along the line of the incision, that also gives pretty good pain relief as well. So that is the local anesthetic. Okay, now quickly describe the procedure to us.
So incision is placed 1.25 centimeter above the line joining pubic tubercle and anterior superior iliac spine. The incision is deepened in the subcutaneous layer. We'll try to preserve the nerves, sir. Once we find the external oblique aponeurosis, we make a small incision with the second knife, and the incision is laterally medially. So the incision is extended medially till the superficial inguinal ring, and we find the cord structure, sir. We have to
take your time, doctor. Don't get tense. You know, I think you're doing well. Yeah.
Yeah, we need to summarize, sir. We are left with 2 minutes.
Okay.
Yeah.
Okay, Dr. Rajan sir, quickly the prime steps in open inguinal hernia repair, and then we will wind up.
Ideal steps and some post-operative complications. Yes.
Yeah, the important thing is a transverse inguinal incision. It's no longer the parallel to inguinal ligament incision. Deepen it to expose external oblique, split external oblique to divide the external ring also so as to get a good exposure. If the nerves are coming in the way, you need to make attempts to preserve the nerves. If they are definitely troubling you, they can be cut safely. There's nothing wrong in having to divide nerves. You open the cremasteric box and then dissect out the sac. The old adage of putting a finger and lifting the whole cord out of the canal is not recommended. After you've dealt with the sac, if it is indirect, dissect only the sac, don't disturb other tissues. Divide the sac in the canal, proximally go and do a herniotomy, distally just lay it open. If it is a direct sac, move the cord structures aside, invaginate the sac and plicate the transversalis fascia over it so that you get a flat surface to put a mesh on. And then you just tuck in a soft mesh. I use these softer large pore meshes, making sure you have an adequate fishtailing on the lateral side so as to accommodate the cord structures without constricting. And use very few sutures on the conjoint tendon side, 2 or 3 absorbable sutures so that they do not give rise to the pain. And we place those sutures in a mediolateral way. Close up with the subcuticular stitches so that they don't even have to come back for suture removal.
Yeah, fantastic.
Yes.
And the common complications, if you, those of you who got my book can see it, there are 10 nice complications in my usual CS style. I've put it down. Seroma, congested scrotum, pain, infection, soreness, that is inguinal hernia, ischemic change to the gonads, pain or due to the symphysis pubis, sometimes chronic sinus formation due to suture problems, and it comes a second time as a recurrence. So these are the common ones that happen. The most troublesome to the patient is inguinodynia, persistent pain in that region, drawing to the patient's attention and affecting his quality of life. Now that's a little difficult condition to be handled.
So that is 3 months after surgery, 6 to 12% is the quoted figure for chronic inguinodynia. The 3 important points is recognition of even though if the patient has a direct hernia, ensure that you go up to the internal ring and ensure that there is no small indirect sac. So the 3 reasons for recurrence is poor technique, non-recognition of an indirect sac, and also medial recurrence because the mesh is not medial enough. So that is another common thing. So these are the 3 things you should remember.
Yes, sir.
Okay.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir. Thank you, Dr. Ashik. Thank you, Dr. Ashik. Wonderful presentation. So we'll move on to the next most important session for the postgraduate exam going students.
1 minute. I would like to tell the student he's done well, and with this kind of presentation, he'll definitely get probably close to a distinction also. You're doing very well, son. Only thing, learn to present without slides. You need to do it on your own at the exams.
Yeah.
And when you come to the operation, you have done it, so you should be able to talk a bit more fluently.
Yes.
This is not a criticism; it is a suggestion. Okay.
Yes.
Your confidence will be reflected on the face of the exam.
Yes.
Yeah. So now I welcome Dr. Nishanth. Dr. Nishanth.
Thank you, sir. I'll just share my screen.
Yeah. So it's the most important aspect, surgical instruments overview. So he's going to talk about the instruments for 40 minutes.
Yeah. Good evening, everybody. I hope I'm audible. I'm Dr. Nishanth, and today we'll be discussing surgical instruments. Basically, this is a part of your Viva OC after your practical examination, after your major and minor cases. So this will be the way we go about this presentation. First, we're going to talk about parts of an instrument, then the various grasping instruments, the retractors, the cutting instruments, then miscellaneous instruments, and then finally a bit about laparoscopic instruments. So what is expected of you in the exam? Once the examiner opposite you tells you to pick up an instrument, the first thing.
Nishanth, just let me stop you. Let the students, if you have any doubts, any questions, please put it in the chat box, and we will answer all those questions as we go along. Sorry to stop you, Nishanth.
Sure.
Carry on.
Yeah. So the first thing when the examiner tells you to pick up an instrument, first name the instrument. Okay. For example, this is an artery forceps. You say this is a Kelly's artery forceps. Hold it like how you hold it during surgery. And then what is the material it's made up of? What are the various parts of the instrument? How is this instrument sterilized? And finally, the use of the instrument, as in what surgeries you're going to use it for, and so on and so forth. And if you know a bit about specialty of the instrument or historical importance, but like I said, the last 2 points come into picture only after you've got the first 5 right. So let's directly jump into the parts of an instrument. We know that the tip has what we call the blade or the jaw. Then you have the joint. Then you have 2 long levers. This is called as the shank. And finally, the handle. The handle part consists of a ring, and few instruments have ratchets, few do not have a ratchet. Now, the ring in the handle, one ring is where your thumb goes, the other is where your ring finger goes, your middle finger supports it, and your index finger is over the joint in order to stabilize the instrument. Okay, so this is how you hold any surgical instrument. Now, the role of the ratchet is to make the instrument self-retaining. For example, you can see that now I've locked this instrument, I've put the ratchet, and you can see that the instrument holds in place. I don't need to add any extra force to keep both the jaws in a position. Now, the same thing, if I don't lock the ratchet, I've unlocked. The minute I leave this, the instrument opens. Okay, so that is the role of a ratchet. It makes the instrument self-retaining. Now, coming to the types of joint, one is a box joint, the other is the screw joint. In box joint, one half of the instrument goes through the hole in the other half of the instrument. If you can see, I don't think it's very clear in the image, but anyway, you'll see that one half of the instrument is through the other. Now, the advantage is that the 2 jaws will oppose or come against each other perfectly. All right, they sit right across each other. So they help you grasp or grab the tissue properly. It doesn't slide around like this. All right, so there's no slipping of tissues. Once you grab something, you know for a fact it's held well. Now, the disadvantage being the small crevices where you can see in the box joint is where the suture can get stuck, especially in a needle holder, and it can irritate you a little bit. Now, coming to the screw joint, you can see that there is a screw here, okay, similar to the screw what you can see here. Here you can see that the instrument doesn't go one inside the other, but it's where the blades slide over each other, all right? So this is more or less used for cutting instruments, where you want the instrument to slide over each other and cut. You don't want to grab something with the scissor, but you want to cut something with the scissor. Now, again, the disadvantage being it's a screw joint. So the joint can become loose, the screw can become undone. So the instrument might not glide across each other perfectly, and it might not cut very well. And when the screw is loose, again, a suture can go get stuck there and cause a little bit of trouble. Now, coming to the serrations. there are transverse serrations and longitudinal serrations. Transverse serration is when the serrations are perpendicular to the axis of the instrument. If this is the axis of the instrument and the serrations are perpendicular, you call them as transverse serrations, and they're more or less traumatic in nature. Now, for example, the advantage is if I grab a tissue and the serrations are like this. So even if one serration slips, the next one will hold. If this also slips, the next one will hold. This also slips, the next one will hold. So you know you have a very good grasp over the tissue. It is something similar to having multiple humps on the road as against a single hump. You tend to slow down a lot more when there are multiple humps. So a transverse serration indicates that it's a traumatic forceps. Whereas longitudinal serrations, this is normally seen in a bowel clamp. All right, a bowel clamp, you're going to see longitudinal serrations. Here, you don't expect to grab. You only expect to occlude the lumen. You're not trying to lift up the intestine with this. You're only trying to occlude the lumen. So any instrument without serration or with longitudinal serrations are invariably relatively atraumatic. I honestly believe there's nothing called atraumatic in surgery, but they're relatively atraumatic. So let's move on to a few grasping instruments. So for the first two, I'll tell you how you're going to answer in the examination, and from the rest, we'll just pick up the speed and go on. So first one is a Kelly's artery forceps. Okay, they can either be a long artery forceps, a medium artery forceps, short artery forceps. They can either be curved or straight. So the minute you pick it up, you hold it in your hand, you tell this is a Kelly's medium-sized curved artery forceps. It has a jaw, it has jaws, it has a box joint, it has a shank, they have rings and ratchet. It has transverse serrations. It is made up of stainless steel and it is autoclaved. It's sterilized by autoclaving and it's used to grasp tissue. Now, the easiest way to remember what the material is and how to sterilize it is by a simple technique. Any metallic instrument that you come across in surgery is always made up of stainless steel. All right. If you don't know what it is, if it's a metallic instrument, blindly say stainless steel, and 99% of the times you'll be right. And if it's something which is made up of a tube, like a Riles tube or a corrugated rubber drain or an abdominal drain, say PVC, blindly say PVC, and invariably you'll be correct. Medical grade PVC will be correct. Now coming to the sterilization technique. Any metallic instrument that is stainless steel is sterilized by autoclaving it, except for a scissor. Sharp instruments, if you autoclave them, they tend to become blunt. So this you're going to sterilize by ETO. Otherwise, any other instrument, you're going to say stainless steel and sterilized by autoclaving. And when I talk about tubes, any material you don't know about it, tell that it is made up of medical grade PVC and it is sterilized by ETO. Obviously, you can't autoclave them, otherwise they tend to melt. Okay.
Nishanth,
so that
one thing, in
yes,
the current
sir.
scenario, are we going to tell people about ETO sterilization?
No, sir, I'm not going into sterilization, only about an introduction.
Should we even mention ETO sterilization?
Yes, sir. We do
because
ETO.
nowadays there is more inclination towards plasma sterilization. ETO has its own implications.
Yes, sir. At least for the exam, if they say ETO, I think it is acceptable for them.
Definitely not autoclave.
Yes, sir. That was the point.
Okay.
All right. So now we have already discussed most of the points. The last 2 points, this is used to grab tissues in order for you to suture, and obviously to hold suture materials, the tip of the suture materials, and it's also used for dissection. All right. Now, the last bit about the artery forceps, you need to know the difference between a straight and a curved artery forceps. Obviously, anything which is curved is made so for a reason, because you can visualize the tip. But at the same time, the disadvantage being, I'll just give you an example. If this is a narrow opening and this is a curved forceps, it might not go in. All right. Whereas a straight artery forceps can go all the way inside and grab the tissue. A straight artery forceps can go into a narrow space at the cost of visualization. Whereas in a curved artery forceps, you get better visualization, but might not be the best of the instrument in narrow areas. So this is a right angle artery forceps. The rest of it will remain the same. The jaws, the joint, the material, the sterilization. The speciality is that it has it has a right angle at the tip. The advantage is that you can see what you're catching very clearly. And the most important point is you can get around the structure very easily. Like for example, assume this is a tubular structure and this is a right angle. If I go around it, just look at the position of my wrist. By doing just this much, I'm all the way around my finger with the instrument. Whereas if I try to do the same thing with a curved artery forceps, please see that I have to go all the way around to make sure that the artery forceps comes all the way to the opposite side. So right angle forceps will help you get around the tubular structure much more easily than a curved artery forceps. Then we have the Cocker's forceps. I'm sure all of you know this looks like an artery forceps, except that it has a sharp tooth at the end. So it is severely traumatic and should only be used on the specimen side. Okay, don't put this on any structure which is going to be retained inside the body of the patient. So normally you have seen gynecologists use this when they're doing hysterectomies. And for surgeons, probably when you're doing a bowel resection, if you're run out of bowel clamps, you can use the bowel clamp for the patient side. And for the specimen side, that is the bowel which is being resected, you can put a Cocker's clamp to make sure that it doesn't slip off and there is no soil or spillage of the contents from the intestine. Oh, and the speciality of the Cocker's forceps was that it was actually introduced for the thyroid surgeries where they used to clamp the superior pedicle of the thyroid. It's no longer being used, but just for historical importance. Then we have the Ali's forceps. This is recognized by the fact that it has teeth, and these teeth in one jaw sit in the groove which is specifically made for it in the opposite jaw. All right. So again, this is a traumatic forceps. It is used to hold fascia and aponeurosis, more or less used commonly in our hernia surgeries. But the thing that you need to remember is it should not grab onto skin. We have a tendency to put Ali's on the skin and lift it up. That's because when you pull, it can cause severe abrasions on the skin. For a patient, it doesn't matter what you have operated on the inside, but what matters is how the skin looks on the outside. So if you end up with a lot of aberrations there, it might not sit very well with the patient. Next, we have the Babcock's forceps. This is still a traumatic forceps, but it's relatively atraumatic. It's slightly less traumatic when you compare it to the other instruments. The specialty is that it doesn't have teeth, but more important is it has a bulge at the terminal end and holes. Now, the importance of this bulge is so that you can hold soft tissue inside this, and the hole inside this allows the soft tissue to bulge out when you hold it. So it will prevent crushing of the tissues. It's giving the tissue some leeway for it to come out and prevent crushing. So this is used to hold soft tissue, intestines, tubular structures. In our hernia surgeries, when we're holding the cord structures, we pick it up and manipulate the mesh underneath, especially in our open hernia surgeries. Then we have the Lane's gland holding or the lymph node holding forceps. It looks almost similar to a Babcock's forceps, except that it has teeth in the front. Now, the easiest way to remember it is it looks like the head of a lion. So that's the reason I remember it as a Lane's gland holding forceps. Again, here it has a bulge and a hole or a hollow area there, which allows the lymph node or the tissue to expand out, preventing crushing. It's very important when you're excising lymph nodes that you excise it in toto and you don't crush the lymph node, because we all know that when we send crushed out lymph nodes, the pathologist always says you won't get the diagnosis what you're expecting. So you always need to send the lymph node in total, and you don't want the capsule to be ruptured. Next, we have the ramp, please. Yes, sir.
One thing for the students, the rachet is there just to hold the tissue, and one click is sufficient. You don't have to hear the noise or crick as if the entire 5 jaws of the rachet is utilized, because one click is sufficient to hang on to the tissues, and tissue respect is extremely important. The more rachets you use, the more trauma it will cause, even though it is an atraumatic forceps.
Thank you, sir. And this is the Rampley's sponge holding forceps, which I'm sure all of you would have seen. It has transverse serrations, which indicate that it's a traumatic forceps. I'm sure all of you know what it's used for, to hold a sponge or a swab in order for painting before surgery, in order to maintain asepsis. The alternate use is we don't do open cholecystectomies a lot nowadays, but it is used to hold the infundibulum of the gallbladder and retract it downwards and outwards in order to open up the calyx triangle for better dissection. Now, this is slightly peculiar. This is a towel clip. One of it is called Mayo, one of it is called Doynes. The common confusion is which is for which. The easiest way how I remember it is Mayo. If you eat a lot of mayonnaise, you tend to become big and fat. So the bigger of the forceps is called as Mayo's towel clamp and the smaller one is called as Doyne's. Other way to remember it is you look at this towel clamp, you make it straight, it looks like a small letter D. So even that's another way of remembering that the name is Doyne's. The towel clip, as we all know, is used to, it has 2 teeth at the tip. This is used to hold the sterile drapes in place. Make sure you don't catch the skin underneath, otherwise the patient will have puncture wounds there, which can be extremely painful. Now, the difference from a Doyne's towel clip is that it doesn't have a joint, it doesn't have a ratchet, but instead it comes with a preloaded spring action. It's a clip. It's exactly like your forceps. It has a preloaded spring. The minute you press it, it opens up, and the minute you release the pressure, it closes. So that's about the towel clips. Finally, we move on to the intestinal clamp. Like we discussed, the intestinal clamp has longitudinal serrations. So it's a atraumatic or relatively atraumatic forceps. Now, I want you to see this. There is, I hope you can see my finger through the whole. This is in spite of closing the ratchet. In spite of closing the ratchet, you can see my finger still there. That means there is still a gap here, which basically means that you don't want the tissues to get crushed. You only want the walls of the intestine to occlude against each other. So there's only use for occlusion of the lumen and not the blood supply. Second thing is, don't close and try to pick up the intestine with this and come to the surface of the wound. You'll end up, the intestine will end up slipping out of it, and you'll end up having soiling of the intestinal contents inside the abdominal cavity. The rest of it will remain the same as we have discussed about the other instruments. Now let's move on to retractors. Now a little peculiarity about, you need to know a few points about the retractor. The first is the terminal bend. Now the advantage of having a terminal bend is that it hooks onto the tissues and doesn't allow it to slip. If there is no terminal bend and it's straight, even with a little movement of your hand, it will slip out. Second thing is, one more thing that you need to know is, first year of post-graduation is called as FRCS, that is Fellowship in Retraction and Cutting Sutures. So unless you know how to retract properly, they won't allow you to go to the second year. Now, you observe that this retractor has a broad handle. Most of us assume that this ring and the broad handle is to put our finger and grasp, which can't be farther from the truth. So just look at this. If I grab hold of this, if this was a single line without any design, if there's a single line, I hold this and grab, you can see that the instrument is slipping. But if it's a broad handle where I'm using the entire hand to hold this and I pull, I have a good grip. It's not slipping. So please understand, retraction is a tedious procedure. So you need to have a good grip to hold on to it. Now this entire thing was made up of solid steel. It would have made it even more heavier and more difficult to retract. That's the reason there are holes here to make it hollow, and they reduce the weight of the instrument, and that's how you retract. So this is a Langenbach's retractor. This was initially used for retraction of the liver. Nowadays, we use it to retract the superficial structures, such as in a hernia surgery. Then we have the Morris retractor.
The thing is, people must understand when they select by retractors, they must think that the length and the width of the blade, that ratio must be 3:1. Anything different from that, either it will be too long or too short.
Okay. Yeah. Then we have the Zerni's retractor. In the Zerni's retractor, on one end, you have how it looks like a Langenbach. Then you have a hollow structure in the middle, and then you have 2 slits at the other end. Now, these slits allow you for better visualization. All right. So if there is some bleeding happening there, imagine you put a Langenbach, the bleeding gets hidden behind the retractor. Whereas with the Zerni's retractor, because it's open, you can actually see the bleeder catch it. Or if you're trying to close the fascia, again, this retraction will help you look at the edge of the fascia when you're suturing it. Now we have the Morris retractor. Now the Morris retractor is almost similar to the Langenbach's. So what they realized in open cholecystectomy was when they used the Langenbach retractor, because it was very narrow, the liver used to flop around this. That is why they came up with the Morris retractor, because it's more broad and they can hold back a bigger area of the liver when they're retracting. And with a little change, you can see that there is a small concavity on the top. So this concavity allows for manipulation. If you're suturing something, gives you a little bit of extra room as compared to having a flat surface. Then we have the Doyne's retractor. Right? The Doyne's retractor is it has a curve even on the side. This is used to retract the urinary bladder, and this curve sits on the pubic symphysis. So this is used in pelvic surgery. The Morris retractor is used in upper abdominal surgeries. So how do you differentiate the two? Both of them have concavity on the top, but when you look from the side, a Doyne's retractor has a curve, a Morris retractor is straight. Other way of looking at it is lift the instrument like this, make this a circle, it looks like a small letter D, it's a Doyne's retractor. And our most favorite retractor, this is the Devers retractor. It has a hook at the end. This allows you to give you good grip, and it has a curve here. It not only can retract the tissue laterally, but with a little movement of your wrist, you can even retract the tissue superiorly. So this is used for retracting deeper structures. So till now, whatever retractors we discussed are usually to retract the superficial structures. The Devers is used to retract the deeper structures. Now, for theoretical purpose, you need to know about this. This is called as the Balfour's self-retaining retractor. This is usually comes with the Doyne's retractor. Now, when I say self-retaining, it obviously means that you need one or two less assistants during the surgery. Now, the same thing, you just need to know the names. This is called as the Dennis Brown ring retractor, and this is called as the Kirshner ring retractor. Now, coming to cutting instruments. There is a basic difference between a surgeon scissor and a tailor scissor. In a surgeon scissor, you'll see that the blade part of the instrument is actually small when compared to the shank and the handle. Whereas in a tailor scissor, the blades are long when compared to the shank and the handle. And most of the times when the scissors what we use in surgery are curved, the straight scissors are invariably used for cutting sutures. So in surgery, whenever you're using curved scissor, it's because it needs good visualization. Cutting is a irreversible step. So think 10 times before you cut anything. So cutting is an irreversible step. So you need to see what you're cutting, and a surgeon cuts with the tip of his scissor. Whereas a tailor cuts from somewhere deep in. For him, he just puts the scissor and one right whack all the way through he'll go. But a surgeon can't do that. He has to go bit by bit and cutting with only the tip. Now, again, in scissors, we have the Mayo scissor and the Metzenbaum scissor. It's very easy to get confused as to which is which. Same funda, apply it again. Big, heavy scissor, which are well built, you call them Mayo. The thin ones are called as Metzenbaum scissor. They have blades, they have a screw joint, they have a shank, they have ringers, but they don't have ratchet. Okay, that is the one difference that you need to say when you're against a curved artery forceps. Now, like we said, you should not sterilize this with autoclaving because they become blunt. So either say Sidex or ETO, or like Sir said, even plasma sterilization can be done. So a Mayo scissor is for cutting dense tissue and for cutting sutures. This is a Metzenbaum scissor. You can see that it is thin and long, and this is used for fine dissection. This is a suture cutting scissor. You can see that the tip is slightly curved upwards. That is so that you can hook beneath the suture, pick it up, look at it, and then cut it. Now, this is one thing that you need to know when it comes to the jaws of a needle holder. This is a needle holder. You can see that the jaws have crisscross serrations. They're neither transverse nor longitudinal. The reason you have crisscross serration is so that you have a good grip on the needle. All right. You don't want the needle to be wobbly when you hold it with a needle holder. When you're going through the skin, you need a firm grip over it. And that's the reason you have crisscross serration, so that the needle doesn't flip inside the needle holder. Now, the second thing which most of you would have missed is that there is a small slit in the jaws of the needle holder. It's a very fine slit, but very important. So just assume the needle is a curved structure. And if you try to compress it between two flat jaws, obviously the curve of the needle will become a bit flat. You're destroying the curve of the needle when you hold it between two flat structures. That is where this slit comes. So the slit will accommodate the curve of the needle when you're grasping it. All right. So if this is a slit, this is the curve of the needle. It'll sit inside the slit, so to prevent that straightening of the needle and weakening of the needle. This is an Adson's forceps. You can get it with tooth, without tooth. And it has certain serrations on it at this area. This is where the surgeon holds on it. The reason for the serrations are there is so that you get a good grip. This is to hold fine, thin structures. So if you have with tooth, they're considered traumatic. If you have without tooth, they are considered atraumatic. Then you have the tissue holding forceps or the thumb forceps. Again, you can have it with tooth or without tooth. And all these tissue holding forceps come with a preloaded spring action. You can see that when I press, it compresses, and when I release, it opens. So this is called as a preloaded spring action. Now, a few things about organ-specific instruments. This is a Joel's thyroid retractor. It has two towel-holding clamps, something like that on the side, and a circular knob which rotated opens up. So these clips are to be put on the platysma. So this is used to raise subplatysmal flaps. If an examiner gives you this, it basically means that he wants to ask you questions on thyroid and thyroidectomy rather than the instrument per se, and that is where the discussion will progress. Then we have the Desjardins choledocholithotomy forceps. Although this is used to grasp a stone, the peculiarity is that it doesn't have a box joint. It instead has a screw joint. The reason is you don't want it to crush the stone, because in the CBD, if you crush the stone, there's a tendency for the small fine particles of stone to either go down and cause pancreatitis and more complications. And the second specialty is that it doesn't have any serrations. It just has a hole to accommodate for the stone. And by chance, because it's a blind procedure, by chance, if you grab the mucosa or some other structure, you won't rip it out when you're coming out because you don't have a good grip. So it is used to maneuver into the CBD and remove the CBD stone. Sometimes you can even use it when you're extracting the gallbladder from a laparoscopic port. The stone is too big. You try to remove individual stones before you get the gallbladder out. So like I said, it doesn't have any ratchet, it doesn't have any serrations, and it has a screw joint in order to prevent crushing of the stone and injuring mucosa. This is a Kelly's proctoscope. It has an inner blunt obturator and an outer hollow sheath. Once it is introduced, the obturator is taken off and you visualize the structure through the sheath as you're coming out. Diagnostic uses are, it is used to examine the anal canal and the distal rectum. And therapeutic uses in perianal surgeries, or sometimes if you want to inject sclerosant to the base of a hemorrhoidal pedicle, you can use a Kelly's proctoscope. Now let's talk about tubes. This is a Ryle's nasogastric tube. So make sure you tell the entire name. The specialty about this tube is that it has 3 lead shots at the tip. This is so that on an X-ray, you can see where exactly the tip of the Ryle's tube is because it is radio opaque. Then you have radio opaque lines. You can see there are thin green lines running all over the tube. These are radio opaque, and you can make out whether the tube has gone straight in, whether there is a kink somewhere, whether it is coiled. This can be made out with the help of these radio opaque lines. Like I said, it is made up of medical grade PVC and it is sterilized by ETO. Now, diagnostically, you can aspirate the contents of the stomach for certain tests. Helps you diagnose tracheoesophageal fistula, and in pseudopancreatic test, you can feel for the Ryle's tube over the anterior abdominal wall. This is called as the Bates test. Therapeutically, it is used for enteral feeding. We use it as a feeding jejunostomy regularly after we do a supramajor surgery, and to decompress the stomach. Strict contraindication in trauma patients who are discharged from the nose. Always have a suspicion of CSF rhinorrhea and do not introduce the Ryle's tube because you might end up pushing the Ryle's tube into the cranial cavity. This is an infant feeding tube. Now, the difference from the Ryle's tube is that it doesn't have lead shots. It doesn't have radio opaque lines. This is only used for feeding infants, or sometimes this can be used for introducing a dye and to do an intraoperative cholangiogram. And if you're doing some surgeries on the finger, like a wedge excision, and if you want some sort of hemostasis, you can tie it at the proximal end of the finger and it can act as a tourniquet for the short duration of surgery, whatever you're doing. This is a Care's T-tube. It has an ascending limb, a descending limb, and a transverse limb. It has radio opaque lines all around for us to help us identify the exact position. And this is commonly used in after CBD repairs. Diagnostically, you can do a T-tube cholangiogram through this. Therapeutically, it protects the repair of your CBD by allowing the bile to flow from the ascending limb through the descending limb. And certain surgeons even use this as a feeding jejunostomy tube, where this bit goes inside the jejunum and this comes out through a stamp technique, and the rest of the transverse limb comes out through the anterior abdominal wall. Now, let's talk about the chest drains and the abdominal drains. Now, you can see that one peculiarity is that in the chest drain, the numbering starts from the last hole. The numbering starts from the last hole. You can see the holes are here and the number starts from here, 2, 4, 6, 8, 10. So it means it's 2 centimeters from the last hole and not from the tip of the tube. Then you have radio opaque lines running all over the tube. And please see that there is a hole here and the radio opaque line stops at the hole. The importance of this is that when you insert as an ICD, a break in the radio opaque line, which you see on the X-ray, will tell you where the position of the hole is. If the patient has surgical emphysema, you don't know whether it is because of the trauma or because the tube has got displaced. So if you see the break in the radio opaque line outside the chest cavity and in the subcutaneous space, you know that that means that you have to push the tube in. So it is made up of medical grade PVC sterilized with ETO. Diagnostically, it can help you identify the origin of the contents of the cavity which it drains. Therapeutic is of course to drain the peritoneal and the pleural cavity. And you can even do pleurodesis using this tube. Then we have the corrugated rubber drain. This can come with or without this radio opaque lines. This is again made up of medical grade PVC and this is used to drain the superficial structures or superficial wounds or surface wounds. Then we have a Foley's catheter. This is made up of either silicone or latex. Okay, and again this is sterilized by ETO. The full name is Foley's two-way self-retaining balloon catheter. So you have 2 channels, one channel to inflate the balloon where you inflate distilled water and the other channel is for aspirating the contents. Similarly, you can even have a 3-way tube where one can help in irrigation and the other channel will act as aspiration apart from the one for the balloon. This is a self-retaining Malakoff's catheter. The flower will help the tube stay in place. Again, this is made up of either latex if it is like this, or you even get plastic ones nowadays that is made up of PVC. This is a flatus tube which we don't use often now but can be kept as an instrument in your examination. This, if it's red, say that it is made up of red rubber. It is not self-retaining and it is usually used to decompress the rectum. It was used for sigmoid volvulus, but it's no longer advised now because of all the hydrostatic or hydropneumatic techniques that we have. Then coming to the BP handle, you have number 3 and number 4. Number 3 basically is for the smaller blades such as 10 to 15, and these are used for fine incisions over the face and the scalp. And number 4 handle are for the larger blades, that is 20 to 24, and these are for the deep, long incisions such as laparotomy. Yes, and finally, let's move on to laparoscopic instruments. This is a Very's needle. We all know that it is used for insufflation of carbon dioxide or to create pneumoperitoneum during the surgery. It has, yeah. So it has an inner blunt obturator and the outer sharp sheath. You can see that the sheath is sharp and the inner blunt obturator has a spring action. This is because the minute your instrument goes beyond the peritoneum, once there is loss of resistance, the blunt part comes out of the sharp outer trocar to make sure that you don't have any visceral injury when you're using this. Now, when they ask you how do you sterilize it, the first thing that you need to say is you're going to dismantle the instrument, thoroughly clean it before you send it for sterilization by either autoclaving or ETO, whichever is the choice of sterilization in your hospital, and both of them are equally accepted. Then we have the ports. I'm sure all of you are familiar. It's available all the way from 3 mm to 12 mm ports or even larger. Again, this has an inner obturator which you can get with either a sharp or a blunt obturator, and the outer sheath with an insufflating channel which will allow the carbon dioxide to either go in or to come out. Then they have what we call as a valve. There are 2 types of valves. There is a flap valve and a trumpet valve. Trumpet is like those newer flutes where you press on a button and the hole goes in. So that's where it gets the name from, the trumpet valve. And this is to make sure that once it's only a one-way valve, which only allows the instrument to go inside the port, but doesn't allow the gas to escape out. So it's a one-way in order to maintain the insufflation. Now we have a laparoscopic instrument. Now it has 3 parts. This is the handle, which comes with the ratchet, the finger rings, and the rotation collar. All right. Now the rotation collar is for when you turn this, you can see that, Now, when I rotate the rotation collar, you can see that the tip of the instrument is also rotating. Okay, so that is what the rotation collar is for, to make you to turn the insert. Then we have the outer insulated sheath. This prevents dissipation of current in order to protect the port when we are using bipolar and monopolar energy, and also to prevent the burns from the current from transferring along the anterior abdominal wall. Now, there are various types of handle. You have the axial handle, which goes along the length of the instrument, or you have a pistol handle like this, where it is at an angle. Like, for example, this instrument is a pistol. It's like how you hold a gun. It's like a pistol handle. Ergonomically, they say the pistol handle is better than the axial handle. And the tip and the jaws are similar to that what we use in the open instrument, except they're named slightly differently. This looks like our artery forceps. We call this as a Maryland. This is a tooth grasper or a tooth grabber. This is a Babcock's forceps, very similar to what we use in our open surgery. Now, when it comes to needle holder, again, in handles, you can either get the axial handle. This is also an axial handle with a ratchet and a ring. And you have the pistol handle. They say ergonomically, the pistol handle is better. And between the straight, the axial and the axial handle with rings, this is the axial handle without rings. Sorry, fare better when compared to the ring with the, when compared to the axial handle with the rings.
Nishanth, you have 5 minutes to go.
Yes, sir. I'm almost finished. 2 more slides.
Yeah.
So when it comes to the jaw, you have a curved jaw and a straight jaw. Again, it depends on the surgeon's preference. No specific advantage, except depending on the area where you're trying to suture in laparoscopy because of the narrow space. Then you have the self-writing jaw. Here, the peculiarity is that it has a groove. So basically what happens, the minute you hold the needle, it will sit exactly in place. You won't have to flip the needle perpendicular to make it right. So when you hold it itself, it goes and sits perpendicular to your instrument in the jaw. And that's what we mean when we say the self-writing jaw. Now coming to the last slide. I know it's a bit complicated. It took me quite some time for me to understand what do you mean by degrees of freedom. We say that in laparoscopic surgery, we have 4 degrees of freedom. What are these 4 degrees? What do they mean by it? What are the 7 degrees of freedom in robotic surgery? And to make it simple, assume my hand is the port. This is the instrument. If the instrument moves up and down, this is 1 degree of freedom. All right, so the instrument can move in this direction. That's called 1 degree, this axis. If it moves towards the camera and towards me, this is the 2nd degree of freedom. All right, so this is, it's like y-axis and an x-axis. If the instrument moves inside and outside of a port, that is the 3rd degree of freedom. And the last one is if I rotate the rotation collar, the tip of the instrument rotates, and that is the 4th degree of freedom. Don't think this is 5th and all. The circumduction or the circular movement is a combination of these 2 axes. So that is not an extra degree of freedom. So up and down, front and back, 2nd, in and out, 3rd, moving the rotation collar, 4 degrees of freedom in a laparoscopic surgery. In robotic surgery, it's a little more complicated, but it has the same 4 degrees of freedom. But please keep it in mind, in robotic surgery, even the tip of the insert can also move. So that can also move up and down, in and out. So that is 5th and 6th degree of freedom. And it can even turn backwards because it's almost like a human wrist. So it can even turn backwards. So that is the 7th degree of freedom. This might not be the most accurate way of describing the degrees of freedom, but I've tried my best to make it simple so that you understand. We have had a lot of instruments to rush through in 40 minutes. I know it's not ideal, but I've given you the basics for you to build up on. And first and foremost, I'd like to thank Surgical Society of Bangalore for giving me this opportunity to present on such a huge platform. And for all the students, if you have any doubts, you can always put it up on the chat box. Or if you want the presentation, this is my email ID. It's lkanta.57@gmail.com. Please send me a mail and I'll be more than happy to share this presentation with you so that it will help you when you're presenting. I'll stop my presentation now, and I would like to take some comments from the seniors if there are some extra inputs that they can give, which are going to help the students.
I think that was very succinct and to the point, very precise presentation. Excellent, Nishanth. I think it's very clear to the students as to what each instrument means.
Thank you, sir.
Well done.
Sir, material, is it important?
Sir,
material of the instrument you were talking. Do
sir,
they ask for the material?
in exam, when I was a postgraduate student, I was taught to tell the material of the instrument as a part of the VIOC. They said that it will fetch a little bit of extra marks. So like I said, most of the instruments we use are stainless steel because they are anti-corrosive and it doesn't rust. If you use any other material, it will rust. So that's the reason we say stainless steel for everything, and invariably we are right.
Yeah. Well done, Dr. Nishanth.
Thank you, sir.
Yeah. So we'll move on to the next session, that is Millennium Gold Medal Award papers. Today we have 4 papers. I welcome Dr. Lakshman K, a senior surgeon, and Dr. Shivram HB to judge this session. Welcome, Dr. Shivram sir, Lakshman sir and Shivram sir.
Thank you. Thank you. If I may come in, I'm sure our consultants who are giving the papers for the award session know about this, but I'm primarily addressing the postgraduates who may be fairly new in giving presentations. When it comes to judging any presentation, particularly for something which is supposed to be an original work as it is in the Millennium Gold Medal Award, the judges take a few aspects for judging. It is done in a very objective and a very methodical manner, and for the benefit of the postgraduates, I might say that the first section is about the originality. Is there anything very original in the idea, in the research question that they have put up? Second, is the design of the study good enough to answer the research question? Is it prospective? Is it retrospective? Is there any comparison? Is it a randomized controlled trial? That gets the highest marks. The third thing is there enough data? Is the data collection sound? Is it complete? Is it analyzed properly? Have the proper statistical tests been applied? That's the third thing. The fourth thing is how good are the slides designed and how well is the talk delivered? Are they very clear in their flow? Do they really understand what they are talking about when they describe their own research? And the fifth aspect is how well they take the questions. All right. So these are the 5 aspects on which any award paper or any paper that is put up in a conference is judged, and I would like our postgraduates to bear this in mind. Thank you very much, and over to the actual session, and we wish the very best to all the consultants who are presenting their papers today.
So to all the speakers, we have 8 minutes. You have 8 minutes for the presentation and 2 minutes for the discussion. So before 8 minutes, just 2 minutes, I'll just give a reminder that you have only 2 minutes to conclude. So please
keeping to the time is extremely important.
Very important aspect. So now I call upon Dr. Ganesh Shenoy as a first speaker. Please proceed, sir.
Harish, suddenly there is a noise in the background. This was not there before.
Yes.
Seems to be okay from my end. And again, a reminder, kindly put the questions in the chat box. Okay, questions in the chat box. And if they are not being able to be answered because of time constraints, I request all the speakers to, after they give the talk, to look for and answer the questions that are in the chat box. Thank you.
Harish, you are keeping the time?
Yes, sir. I am starting now.
Good evening, sirs. I'm going to present my paper on laparoscopic repair of recurrent inguinal hernias following a previous laparoendoscopic repair. The incidence of recurrence after a laparoscopic TAPP or a TEP procedure is anywhere up to 4.3%. And the most common approach of management of recurrence following an open repair has been the laparoscopic repair, and the recurrence following laparoscopic repair has been open surgery. But when a patient has a recurrence after both an anterior and posterior approach, then the comfort level of the surgeon and the expertise of the surgeon in managing such recurrences counts. According to International Endo-Hernia Society guidelines, redo laparoscopic surgery for a recurrent following laparoscopic can be done, and it should be attempted only by an expert in laparoendoscopic inguinal hernia repair. Laparoscopic redo hernia repair are fraught with challenges as the previous preperitoneal space is violated because of the previous surgery, previously placed mesh, which is polypropylene most of the times, and the previously placed tackers. There exists a high risk of injury to the urinary bladder and the neurovascular structures in this redo laparoscopic hernia repair. The purpose of the study is to examine a series of re-laparoscopic mesh repair for recurrence of inguinal hernias and present my technical experiences and the clinical outcome in this subset of the patient. Before taking a decision to do a laparoscopic repair, a detailed discussion of the patient with the patient has been done. The patient has been explained regarding the risk involved in the procedure and the necessity for the open repair or a conversion if required, keeping in mind the safety of the patient as primary intent. This is a retrospective study from a prospective database. The study period was from March 2015 to December 2020. The number of patients were 14 and all were males. And I could get the previous operative record of 11 patients. And based on the previous records and intraoperative findings, what I find that the most common cause of recurrence in my study was inadequate parietalization of the cord or inadequate dissection. Because when there is an inadequate dissection, we tend to put a smaller size mesh, and other technical drawbacks were the insufficient mesh fixation or the mesh size and the mesh migration. Among the 14 patients, 7 patients underwent TAP during their primary laparoscopic hernia repair and 6 were TP. 1 patient had undergone an open surgery initially with the patient with the hernia recurred. Then he underwent a laparoscopic TAP procedure. So it was a recurrence following both anterior and posterior approach. This patient also underwent a redo laparoscopic TAPP procedure. 6 patients were diabetics and 2 were hypertensive, and 1 patient was both diabetic, hypertensive and had an IHD. He was on anticoagulant which was stopped 7 days before the surgery. The primary center of primary surgery, 2 patients underwent surgery at our center and 12 patients underwent in other centers. During the laparoscopic repair, 13 patients underwent a TAPP procedure and 1 patient had done an ETP mesh repair. This is a patient with an R2 inguinal hernia, that is, he had a recurrence following both anterior and posterior mesh repair. So in this, the primary port in the epigastrium, primary port was placed in the epigastrium higher up. The reason is you can get an enhanced view of the myopectoral orifice of the prostate. Previous mesh is never to be removed. So when you raise the peritoneal flap in a TAP, in such cases, see that the mesh or the previous fibrosis lies on the peritoneal side and not towards the abdominal wall side. When you enter the space of Regius, the bladder will be densely adherent, or there will be a lot of fibrosis in the space of Regius. Doing such things, what I have made is I have inflated the bladder with normal saline so that the urinary bladder is distended, and it helps in detecting planes in the space of Regius. And also, if there is any inadvertent injury to the bladder, it will be evident, can be repaired intraoperatively. So when you dissect the indirect sac and when it is separated from the cord structures, I usually transect the sac closer to the internal ring and not ligate the sac, because in such cases, there will be a rent over the peritoneum which can be closed during the peritoneal closure. This is a patient who had undergone a laparoscopic left TAPP mesh repair and also an open posterior rectopexy. So we had an infraumbilical big scar and as well as the previous scars of the TAP repair. So he had presented with the bilateral inguinal hernia, which the left side was recurrent. Here I approach the right side first. So it's always safe to enter the virgin area rather than the scarred area first. So right-sided flap was right first, right-sided space of Regius was defined, then the right side was dead. Then the flap was raised on the left side. There was a lot of fibrosis in the space of Regius, and also we had a sliding sigmoid colon. So the flap was raised, placing the primary port in the epigastrium. Then the entire sigmoid colon was reduced. Then the sac was separated from the cord structures, and this is the spinal dissected space. So since the dissection was involved too much, we have placed a vacuum drain in the retroperitoneal space of Regius. Then the peritoneum was approximated. Any buttonholes in the peritoneum was approximated. This is a patient who had a left inguinal hernia. You can see the mesh migration here. You can see the previous trackers, and he had a medial recurrence. So the flap was raised, cutting the median umbilical ligament, which is not recommended. The patient was catheterized. Then once the flap was raised, when the space of Regius was reached, And then when we proceed with the lateral dissection, you can see the external iliac artery there, and the mesh was densely adherent to the external iliac artery. The medial recurrence, it didn't have a lateral recurrence. The medial recurrence was reduced. And then since the mesh was adherent to the external iliac artery, no more attempt was made to remove the mesh away from the external iliac artery. Otherwise, we would have ended up with devastating complications. Then the polypropylene mesh was placed and the peritoneum was approximated, leaving the previous mesh in place.
You're left with 2 minutes.
So we could encounter a lot of challenges. Sometimes the inferior epigastric artery used to come on the way of a dissection, which was ligated and cut. Mesh was dense into the abdominal wall. In such cases, we had difficulty in raising the flaps. There was some buttonhole defects over the peritoneum, which was closed. One case, we had a bleed from the inferior epigastric artery while raising the peritoneal flaps, which was controlled with the transfacial sutures, and the procedure was continued. The patient who underwent an ETP mesh repair, the bladder was distended, and then I had some suspicion of bladder injury. Then the bladder was inflated with the methylene blue dye, but there was no extravasation of the dye. But I kept the Foley's catheter for 5 days, but the patient was comfortable. Doing the redo repair, there were 12 direct defects and 2 direct defects and 12 direct and indirect hernia defects, showing that the indirect hernia, because of the lack of reduced peritalization or the lack of peritalization or decreased peritalization of the previous surgery or a small size mesh, the mesh should have herniated, the hernial sac would have herniated behind the mesh because we don't fix the mesh inferiorly. These are the series of my patients, 14 patients who underwent redo laparoscopic mesh repair, 13 underwent TAPP mesh repair, and 1 underwent ETP mesh repair, 3 were bilateral TAPP mesh repair. The average operating time for a unilateral tap was 80 minutes. For a bilateral, it was 110 minutes. And for the ETP procedure was 90 minutes. While doing the ETP mesh repair, the patient had a peritoneal rent, which was managed by various needle insertion. All the patients were started orally 6 hours after surgery and the soft bed the next day. 12 patients were discharged the first postoperative day and 2 were discharged the second postoperative day. This is a follow-up period of, it's from 6 months to 6 years. 4 patients are seroma and 3 patients are chronic groin pain, which resolved with conservative line of management. Nobody had a recurrent hernia or a mesh infection. To conclude, the redo laparoscopic mesh repair is difficult and it has to be taken after detailed discussion with the patient. Both TAP and TEP are acceptable, but my choice is the TAP for a redo mesh repair because TEP seems to be a darting stance because of the additions of the preperitoneal space and the scarring involved. TEP can be tried if there was no fixation used primarily. There is just an assumption that the mesh remains on the peritoneal side when the no fixation was used. But I personally prefer a TAPP mesh repair whenever I attempt a redo repair. There was no conversion to open surgery and the previous mesh never to be removed, and we should always use a larger mesh and fixation is a must.
Time is up, sir.
So the take-home message is redo laparoscopic repair for recurrences should be tried only by an expert who has good volumes, who had done a lot of TAPP and TEP earlier, and it is feasible and effective in a safe and experienced hands.
Yeah.
Thank you.
So please unmute, sir. Lakshman, sir, please unmute.
Ganesh, did you have a protocol for whom you would offer a redo laparoscopy versus a redo open surgery?
Yes, sir. Patient who had a lot of comorbid conditions, who are very elderly, more than 70-year-old, and they were not fit for general anesthesia. Such patients had opted an open surgery also.
But we have no data on this group about these things.
Yes, sir. It's not a comparative study which I've made because it's just a retrospective study from the Prospective database where I had done about 14 cases of redo laparoscopic mesh repairs.
If you are having a good number of patients as you do, what would you consider? What kind of study would you consider to give us the information about a comparison between the two? How would you design such a study? Because that is what is required. When there is a controversy, 14 cases of retrospective studies is really considered anecdotal. And as you know, anecdotal studies do not have a very high value. So a comparative study with a regular protocol, what kind of study would you design?
Yeah, one is the duration of stay, second is the pain aspect, the duration of stay, and the follow-up period. If the patient had recurrences following a lap repair compared to open repair. But in my case, the duration of stay was almost the same. 12 patients got discharged on the first day and 2 patients got discharged on the second day. And there was no recurrence again following surgery in the period of 6 years. So I followed up the patient.
Now, that brings me to the next thing. Any study, we need to have a protocol for the follow-up that was planned? How often were they seen?
Yeah.
Who saw them? What was done when they were seen? What is the completion of follow-up?
Yeah.
We had no data on that at all.
Yeah, the patient was, I had presented the data, sir. The patient was followed up from period of 6 months to 6 years. So they came
No,
to the
what was the protocol that was followed? How often did you see them?
first week following surgery, then the first month, third month, 6 months, and then yearly. And all the patients have turned for follow-up.
It would be very useful to have this data in a table when you are giving us the data.
Yes, sir.
And you also mentioned about an average time for the two operations.
Yes,
but it's good to have the minimum and the maximum.
Okay.
Yes,
Without it, your time, average time might look arbitrary. Yeah.
Yes, sir. Shuram, sir, anything to say?
In your patients, how do you think obesity has a role to play in recurrence, or you had any difficulty because of that? High BMI patients?
Yeah, luckily we didn't have any high BMI patients, sir.
Right. You think
obesity definitely is a factor to be considered for recurrence.
Right.
But in my 14 patients whom I had done, there was no patient who were obese or BMI more than 30.
Yeah. Thank you, sir. Time is elapsed. Thank you, Dr. Ganesh Shenoy, for a wonderful presentation. We'll move on to the next speaker, Dr. Vinay HG. Dr. Vinay?
Yes, sir. I'm starting.
Yeah, please. You have 8 minutes for presentation, sir.
Yeah, sir, is my screen visible, sir?
Yeah, visible.
Yes, it is.
Yeah, good evening, senior consultants and all my dear colleagues. I'm Dr. Vinay, Associate Professor from Vidya Institute of Medical Sciences. So I am presenting here my paper on two-port laparoscopic retroperitoneal pancreatic necrosectomy with reference to the improvement in morbidity and mortality with a less invasive approach. So the main treatment of pancreatic necrosis is usually conservative unless there are other side effects like associated with secondary infections or the patient is not responding. So severe pancreatitis is, as everyone knows, carries a significant risk of potentially life-threatening complications, and the mortality rate for the same remains around 15 to 30% in presence of infected necrosis. But as now, with improvements in critical care and as you have got better imaging techniques, early radiological investigations, and with the presence of evidence-based medicine management, so there is a gross reduction in death rates, especially in tertiary centers which provide multidisciplinary care. Pancreatic necrosectomy, it can be done open, usually through a midline incision, and it is usually a transperitoneal access to remove the necrotic tissue. In such case of open necrosis, because of the morbid condition of the patient, usually patient will require repeated laparotomies to ensure the complete debridement as well as thorough removal of the necrosis. And the perioperative mortality in such cases, it varies from 11 to 50%. So the main advantage of minimal access approach are a reduction in the systemic complications as well as a lower risk of developing new organ failure. So at our center, we practice pancreatic necrosectomy using a variety of minimal invasive procedures as well as open techniques depending upon the feasibility as well as affordability of the patients. So in this technique, that is two-port retroperitoneal pancreatic necrosectomy technique, we felt that it is effective and safe with minimal morbidity, and it's technically feasible as well as the tolerance by the patient is better when compared to open approach. So it's an observational clinical study. In our study, we considered 13 consecutive patients which were transferred or admitted to our unit, and the diagnosis of acute and the clinical as well as radiological evidence of infected acute necrotic collection or walled-off necrosis was present, and the duration of study was over a period of 3 years. and a patient with signs of infection, or if the patient is not improving after 48 to 72 hours of medical management. So we used to treat the patient by two-port retroperitoneal necrosectomy, as it has been described.
Sir, are you able to, sir, Dr. Lachpan, sir, are you able to see the slides?
Yeah, we can read it with a little bit of difficulty, but it's okay. Please carry on, Vinay.
Okay, yeah.
So these were the statistical methods which were employed in our study. So the main
your slides don't seem to be moving.
Yes, that's my concern. Vinay,
sir,
your
the slides are not moving.
We can't see the slides. Only we can now see the introduction slide. That's it. That is stuck up there. Can you reshare it?
Don't we have the PPT slides with us?
With us, just to stop sharing, we will share your slides, Vinay. Please stop sharing. We will slide. Sharath. Yeah, Sharath. Dr. Vinay, you stop sharing.
Yes, sir.
Yeah, Sharath, please.
Harish, how do you assess the time now?
I think we have not seen the slides.
Better restart.
Restart, sir.
Is it okay?
Yes.
Then start.
Yes.
No,
time.
give him an advantage of 2 minutes. We must have lost 2 minutes in that. So please go on from where you are.
I'll start from introduction, sir.
I think you have to start with some 3 to 4 slides later. Introduction we have just seen.
Right.
So methods, it's an observational clinical study.
Yeah.
So 13 patients were considered in our study that were transferred or admitted to our unit, and with the diagnosis of acute necrotizing pancreatitis over a period of 3 years. So, and those patients with clinical as well as radiological evidence of infected acute necrotic collection or walled off necrosis were considered, and patients with signs of infection, that is clinical signs of infection, and no clinical improvement in the patient even after 48 to 72 hours of the treatment. And we consider this two-port retroperitoneal pancreatic necrosectomy, which has been described as under. So these are the statistical methods which have been employed. The main tool for the procedure was the CT scan. So in this CT scan, we could calculate the depth, volume, as well as distance and direction through which we could approach the abscess cavity. So patient under general anesthesia, along with that, we used to infiltrate the tract with local anesthesia, and as well as the same needle or syringe were used to confirm the approach to the abscess cavity, whether we have entered the cavity or not, by aspirating the pus. Once we confirm the needle is in the abscess cavity, we used to use a 5 mm trocar to enter the abscess cavity. Initially, suction of the abscess cavity will be done. So this is a small video. Once we have entered the video, this will be the image or intraoperative finding. So all the pus used to be suctioned out. Thorough irrigation with saline used to be done, followed by necrosectomy, that is debridement, used to be done with a tooth forceps. So once the abscess cavity starts bleeding, that is the sign which indicates that complete debridement or removal of the necrosis is done. So the raw area which we can see, is the cyst wall or abscess cavity wall. So once the bleeding has started, it is a sign that we have reached the complete debridement. So this is a photo of necrosectomy specimen, and post-op we used to keep 2 drains, one for irrigation, one for drainage. Coming to observation and results. So in our study, most of the patients were of the age group of 40 to 50 years, and alcohol was the common etiology in our study. So time to the first procedure, that is when the first procedure or invasion was done after a 35 to 40 days of onset of acute pancreatitis. And the time for discharge is approximately 11 to 15 days after the procedure. So the total duration of stay in most of the patients was around 25 to 30 days. And the commonest complications which we encountered was pancreatic fistula following the procedure. And in such case, the patient we used to keep a drain along with colostomy bag, and we used to discharge the patient with the colostomy bag, and followed up. Gradually, the fistula output used to reduce, and patient would be stable after removal of the drain tube. So, two-port laparoscopic retroperitoneal approach has the advantage of directly accessing the pancreatic bed. It provides good visualization of the necrotic tissue, and as well as it has enhanced view of the cavity containing the necrosis, and more efficient debridement can be done laparoscopically under vision. So it has avoidance of creating pneumoperitoneum in a critically ill and potentially unstable patient, and as well as less dissection is done, which is technically easier, and as well as it avoids contamination of the peritoneal cavity by infected material from within the pancreatic bed. The disadvantages of the study were it's not a randomized controlled trial, and it's not a direct comparison done, and small number of cases are done till now. The median number of procedures per patient was only one, and it was lower than most of the non-invasive necrosectomy series, which usually varies from 3 to 5. And our 90-day post-procedural mortality rate was 0. Outcomes are extremely favorable with other published mortality rates following necrosectomy, that is around 0 to 25%. To conclude, two-port retroperitoneal pancreatic necrosectomy, it offers benefits superior to traditional open surgery. Superior visualization and better access to the necrotic cavity is achieved, as well as fewer complications and faster recovery for the patient. So early minimal invasive drainage can be done, considered as step-up approach for better patient compliance and improved patient morbidity. Thank you.
Shivram, will you go with the questions first, please?
Right. Rohit.
Vinay.
Yes, sir. Yes, sir.
Vinay, yeah.
Yes,
what are
good
your
evening, sir.
contraindications for this procedure? You had a study design for this?
So contraindications mainly were once if it was not feasible to approach transpercutaneously, sir, like the abscess cavity is in the lesser sac, or when there is a bowel intervening, overlapping, or if there is pancreatic ascites. So these and all were considered as contraindications.
You are approaching retroperitoneally.
Yes,
There is
sir.
no question of bowel coming there.
Yes, sir. No, sir.
Isn't
If
it?
the collection is not in the retroperitoneum, like if it's in lesser sac or if there's pancreatic ascites, so these and all we considered as contraindications, sir.
Right. So,
Sharath, can I please, sorry, Sharath, please have the conclusion slides of Vinay. I need to ask questions on that later. Yeah, thanks. Sorry, Shivram, please go ahead.
yeah, okay. So after the surgery, there were patients who were on ventilators, or they were extubated, or what was your post-operative morbidity? You said no mortality.
Yes, sir. Post-operative morbidity were mainly in form of bleeding, sir. Few patients had bleeding, and most common was pancreatic fistula formation, sir. So around 5 patients, they had pancreatic fistula, which was treated conservatively. That is, we used to discharge the patient with the drain into. We used to connect a colostomy bag. We have discharged the patient, sir, and followed up in the OPD weekly basis, sir.
You said the end of the necrosectomy was indicated by starting of the bleeding.
Yes,
is it
sir,
this
bleeding.
fair statement or is something else? Anyway, you will stop because of the bleeding. But how are you sure that your necrosectomy has been complete?
So we could visualize the complete cavity wall, sir, which is red in color.
Okay. Dr. Lakshman, carry on.
Thank you. Vinay, you
Yes, sir.
mentioned a few statistical tests that you applied.
Yes,
But
sir.
these are usually applied on data
Yes, sir.
between, say, comparisons. A t-test is a comparative test. I haven't seen a single table with data from your series.
Yes, sir. We didn't use comparison in this study.
So you
sir.
have
Only-
applied no statistics then. And
Sir,
you also didn't give
oh.
us any kind of significant data. What is
On-
significant, what is not significant.
Only
What
for
was-
the observation results, we have used percentage, sir. Other than
But
that,
that is not you. I think your statistical test you mentioned t-test, which
Yes,
is a
sir.
comparative test.
Yes,
Number
sir.
two.
We are not. Yes,
yeah.
sir.
Number two. It's okay.
Yes, sir.
Please keep it to conclusion. Yeah. Conclusion of every paper
Yes,
must
sir.
be based on data in that paper.
Yes, sir.
Okay. And you
Yes, sir.
look at this. Early minimal invasive drainage can be considered.
Yes,
But
sir.
you have no comparison between early and late minimally invasive drainage in your series.
So
I
that
understand
is-
it is a small series. I don't mind. I'm
Yes,
not
sir.
fixed on the numbers. But
Yes,
you have
sir.
no comparison between doing it on day 20 versus doing it on day 40, for example. That is a conclusion you have come to. What
Sir.
is the data to support that conclusion?
Sir, actually, the data is from other studies, sir, which have compared it, which have mentioned
So you must
in the
have
previous
something
study.
which says about comparative, with
Yes, sir.
historical data. What is the historical data? There must be actual data for that, right?
Sir, in discussion, I have mentioned few studies, sir.
Yeah, but
Which
what is the
along-
data? Without the data, if you give a
Yes, sir.
conclusion, it becomes an issue. All right, fewer complications and faster recovery. Again, I saw no data on that in the
That's
paper.
what, sir, which I compared with few other studies, sir. That is what I have mentioned in discussion.
Are you understanding what I'm saying?
Yes, sir. Yes, sir. I know.
What was the complication rate in your study compared with the historical controls? Have you put a table for that? I did not see any data unless I missed it.
Yes, sir. 2
Is
minutes
there-
has elapsed. I think we'll move on to the.
Yeah, but can we please allow him to answer before
Yes,
we
sir.
move on?
Yes.
Yes, sir. In my study, I have not compared with other
Yeah, so-
type of
yeah.
approach, sir.
All right. Okay. Thank you.
But
Yes.
yes, sir.
Thank you, Dr. Vinay,
Yes, sir.
for a good presentation. I call upon Dr. Rohith Kumar. Please share the slide. Dr. Rohith.
I'm not allowed to share still.
Yeah.
If somebody is already sharing, they must go out.
Yes, sir.
Yes.
Am I audible, sir?
Yes.
Yes, you are.
Yes, Rohith.
Can I start, sir?
Please.
Make your slides.
Yeah. I'll start, sir.
Please.
Good evening, all. I'm Dr.
Please
Rohith.
go into full screen.
Full screen. Make it full screen, Rohith.
It's in full screen in my slide, sir.
Okay.
No, sir.
No.
I'll share again, sir.
Yeah, please.
Is it full screen, sir?
No.
Harish, why don't we open it for him?
Yeah, I can. Sharath, Rohith, can you stop it and we'll share
Sir,
it
actually,
from
I'll just do it, sir. Just a
yeah,
minute.
please.
Yes, sir. Can I go, sir?
Yeah, it's full screen now. Go on.
Yeah.
Yeah, you have 8 minutes, Rohith.
Yes.
The time
Thank you, sir.
starts now.
Yeah. Good evening, all. I'm Dr. Rohith Kumar, presenting from Manipal Comprehensive Cancer Center. My paper is on timing of bowel anastomosis in cytoreductive surgery and HIPEC. Does it matter? I have no disclosures. Of all the complications in CRS HIPEC, gastrointestinal leak is one of the dreaded complication with a complication rate of 5 to 34%. The important feature in CRS HIPEC is the presence of heat and chemotherapy, which affects healing of tissue. We have various guidelines and many strategies in HIPEC, but there is no consensus guidelines on protocol regarding timing of anastomosis to perform before or after HIPEC, because each technique has its own advantages and disadvantages. The need for the study was to evaluate there is no consensus guidelines worldwide regarding timing of anastomosis. We don't have available literature with a head-to-head comparison between two approaches. Our objective was to evaluate if timing of anastomosis done after or before HIPEC had effect on bowel complication rate. Bowel complication rate was defined as anastomotic leak or perforation. Anastomotic leak was defined as any postoperative disruption of the enteric contents from the anastomosis leading to leakage of content. and bowel perforation was defined as any discontinuity between bowel occurring at a site away from anastomosis. It was a retrospective review of prospectively maintained database from June 2013 till December 2019. All patients who underwent CRS HIPEC with at least one bowel dissection anastomosis were included in the study. We have two teams at our institution. All of them have got a single chief surgeon and two assistant surgeons. All are trained and regularly perform advanced cytoreductive surgeries. One unit performs HIPEC anastomosis before HIPEC and the other after HIPEC. The technique of anastomosis, all the anastomosis was stapled, reinforced with second layer of non-absorbable 3O silk. Thorough inspection of bowel was done before closure. If it was not possible to take a second layer for a low anastomosis, or if it was a bowel that is irradiated, a covering stoma was done. The following statistics methods was used. Univariate and multivariate analysis was done to identify the risk factors for bowel complications. These were the factors that were used to find out the factors affecting. Results: of the 370 patients who underwent CRS HIPEC, 214 were had at least one bowel dissection and anastomosis. Of them, 110 had anastomosis before HIPEC, 104 after HIPEC. Most of the baseline characteristics were comparable between both the groups. Ovarian cancer was the most common organ of origin in our study. Nearly 1/3 of our patients had a pre-surgical score of more than 2, and nearly 2/3 of our patients had interval and recurrent surgery. The median hospital stay was around 14 days, and bowel recovery was around 6.5 days. When we looked at bowel complications, the large bowel was the most commonest bowel dissection, around 58%. We had a stoma rate of around 12.1%. Our perforation rate was 3.2%. Leak was 4.2%. Both them are comparable between both the groups. When we looked into management of the complications, all the complications except for one was conservatively managed. All of them required surgical exploration and all patients were salvaged. The conservatively managed patient had a stoma and a colorectal anastomotic leak, which was managed conservatively. You can see here in this the surgery that has been done in both the group, which is comparable. Nearly 1/3 of the patients had multivisual dissection. Overall morbidity was also comparable between both the groups. When we looked into factors, on univariate analysis, duration of surgery more than 10 hours, blood loss more than 850 ml, recurrent surgeries, multivisual dissection, and number of anastomosis more than 2 was significant. But on multivariate analysis, pre-surgical score of more than 1, recurrent cancers, and number of anastomosis more than 2 was significant. We have been performing major cytoreduction since 15 years now, and since it's a tertiary care cancer center, we have always get advanced diseases coming for our surgeries, which is reflected with higher PCI in my study, nearly 1/3 having more than 2 PSS score, nearly 50% requiring bowel dissections, and nearly 30% requiring multivisual dissection. In most of the studies comparable all over the world, the complication rate between anastomosis before and after HIPEC in individual studies was around 5 to 34%. When we looked into factors, these were the factors that were found in various studies that predicts the bowel complication rates. This was a recent study that was published in 2020, which was a retrospective review of US HIPEC collaborators between 2000 and 2017. Among them, they predicted that they had male gender, left resections, and preoperative albumin as important factor. Technical factors such as staple versus hand-sewn, timing of anastomosis, and chemotherapy were not associated with anastomotic failure. They concluded that operative technique may be individualized based on patient consideration and surgeon preference. In our study, as mentioned, pre-surgical score more than 1, recurrent cancers, and number of anastomosis more than 2 was significant. Nearly 1/3 of our patients had recurrent cancers, had received multiple lines of chemotherapy, and required extensive surgeries and more bowel dissections. This could explain increased complication rate. Pre-surgical score more than 1 meant that patient had been explored by multiple abdominal pelvic regions in primary surgery. This resulted in adhesions and making them more vulnerable for multiple serosal tears and increased risk of bowel complications. Since all the patients in our study had stapled anastomosis, the method of anastomosis, that is hand-sewn with a staple, was not commented upon. My limitations: this is a retrospective study. However, all the data was entered prospectively. The number of gastrointestinal complications is less in number. However, the overall percentage, that is around 7.4%, is similar to that mentioned all over the literature. The paper would have got more value if a propensity score matching would have been done. But since most of the confounding variables at the baseline were statistically not significant, our biostatistician was of the opinion that we could avoid propensity score matching. I would conclude by telling that anastomosis of bowel done after or before HIPEC does not affect the bowel complication rate, because patient and tumor related but not technical factors are associated with bowel complications. Operative technique may be individualized based on patient considerations and surgeon preference. The timing of anastomosis can be done as per the discretion of the operating surgeon. These are my references. Thank you.
Rohit, I have two questions. When you're considering an anastomotic leak rate, we all know that the radiological leak rate is perhaps 2 times that
Yes.
of a clinical leak rate.
Yes,
In
sir.
your study, you haven't mentioned whether the leak was a clinically significant leak or whether it was radiologically detected.
Sir, most of the patients had a clinical presentation, that is the abdominal signs with fever and constitutional symptoms, and they were also evaluated on CT scans. Sir.
Yeah. The point I'm making is something that is not clinically evident may still show a leak on radiology.
Yes,
so
sir.
would you have considered, for the sake of a study, doing routine radiological investigations?
Yeah, so actually I had not mentioned this as a fact, but most of the patients are referred from outside here. So before discharging the patient, all of our patients on the day of discharge or one day before discharge, we usually do a CT scan so that they go home without any apprehension, and we can confidently tell them that you are safe and anastomosis was secure, sir. Usually we do it, sir.
I accept your stand on the propensity score matching, and because the confounding factors
Yes, sir.
were matched in both sides, even though it's good to have independent data. But there are other confounding factors which perhaps you have not considered. What about comorbidities like diabetes, like other immunocompromised state, other than the cancer state, nutritional status? Those things definitely have an impact. Without data on that, how can you conclude that there is no difference between these groups?
So the performance status and morbidity status is the only one that was not considered, sir. I agree for your whatever.
Particularly
you're mentioning,
nutritional status would be extremely important, wouldn't it?
Yeah, sir. Albumin was considered in that multiple factor that I analyzed, sir.
Okay.
Pre-albumin level. In that pre-albumin level was not found to be significant, sir.
Thank you.
I had included, sir.
Thank you. Shivram?
Yes, Rohit.
Yes, sir.
After concluding all this study, will you continue to do both, or you want to continue doing post HIPEC anastomosis?
Yeah, sir. Actually, now since after the analysis of this, we are all our anastomosis is always being performed before the HIPEC, because after the HIPEC is done, usually most of the technical thing that has to be done while doing anastomosis, it takes more. The time is not factor, but the surgeons are usually drained to stand after that. So if the anastomosis is done before HIPEC, then after the anastomosis, the HIPEC is done. After that, we do a complete evaluation of the bowel inch by inch to see if there is any dehiscence. On following that, we go ahead, sir. So now we are actually doing all the anastomosis before HIPEC, sir.
Okay, thank you.
Yeah, thank you, Dr. Rohit.
Thank you,
for
sir.
presentation. Now I welcome Dr. Sreekar Pai. Dr. Sreekar, sir, you're there?
Can you hear me?
Yes,
yeah.
yes,
Please
Sreekar, we can.
share your slides.
Shall I? Yeah, thank you.
Yeah.
Can you see the slides, sir?
Yes, you have 8 minutes
Yeah.
for presentation. Please proceed, sir.
Good evening, chairpersons. Today, my study is on the prospective role of a laparoscopic intervention for intestinal obstruction. So, intestinal obstruction can be defined as the impairment of the normal passage of intestinal contents, which can be either by mechanical obstruction or at times abnormal intestinal motility. Small bowel constitutes about 80% of the obstructed changes. The laparoscopic surgeries do have fewer post-operative adhesions than open surgery is a unknown fact. So we are trying to know whether we'll be able to do laparoscopic surgery in small bowel obstruction and see the feasibility. The first laparoscopic surgery was done by More in 1972 for laparoscopic adhesiolysis, and it has been accepted further on. So our study has been a prospective study over a period of 1.5 years, and we have divided into two groups. One is the laparotomy group and the other one is the laparoscopic group using Microsoft Excel sheets. The inclusion criteria has been age of 18 to 80 years with intestinal obstruction, acute or subacute, but mainly hemodynamically stable and without any signs of strangulation. Exclusion was who had contraindication to general anesthesia and to that of laparoscopy. The outcomes assessed were time to flatus, time to water intake, soft diet intake, and length of postoperative stay with postoperative complications, and patients were followed up for a period of 3 months. The statistical method, we found that around 29 patients were required in each group as a minimum. The total number of cases that we took for the study were 71, and of that laparoscopic intervention was done in 34 and laparotomy in 37. So in the laparoscopic intervention, we've had age of average of 41 years with the equal distribution of male to female. The main symptoms on presentation were pain abdomen in 70% and obstruction features in about 35%. Signs, abdominal tenderness and distension were the main signs, and previous operations were noted in 6 individuals that constitute about 17%. The main previous operations were gynecological, that is hysterectomy, cesarean, and one of them was previous IPOM and appendicectomy. The investigation, CT scan was our main mode of investigation, and it showed obstruction in all, and one of them mass omental thickening in about 9 individuals and mesenteric extensive mesenteric lymphadenopathy in one of them. The X-ray abdomen and ultrasound was performed in the remaining patients. The surgeries which were performed were mainly adhesiolysis in about 45% of the patients, and tuberculosis was noted in 7 patients, small bowel stricture in 3, and the laparotomy conversion was in about 26%, that is about quarter of the patients, and postoperative complications were noted in 14 people postoperative. The laparotomy was done in 37 cases with an average age of 47 years and a male preponderance of 55 years. The pain abdomen was noted in 89% of the patient, and vomiting was noted in 13% of the patients. Previous operation was noted in 10 patients, which was cholecystectomy, appendicectomy, and laparoscopy surgeries, as well as gynecological surgeries. The CT scan again was the main form of our investigation, and X-ray abdomen and ultrasound was in the other things. The CT scan also showed mass in one of the patients and omental thickening in 9 patients, again mesenteric lymphadenopathy in 1. The surgeries performed were adhesiolysis in almost 50% of the patients, with the 3 patients requiring having Cox abdomen requiring biopsy, stricture in 4 individuals, bowel gangrene was noted in 2, perforation in 2, and large bowel malignancies were noted in 3. And one of the individuals had appendicitis. The postoperative complications was about 18% of the patients. These are the comparative outcomes. So time to flatus in the laparotomy group was about 3.62 days versus 2 days in cases of laparoscopy, which is statistically significant. And time to water intake was 4.65 days in cases of laparotomy and 3 days in laparoscopy. And soft diet intake was 5.3 mean in case of laparotomy group and 3.2 in case of laparoscopic group. And postoperative stay was 11 days in laparotomy group and approximately 5 days in the laparoscopic group. All these were found to be statistically significant. Postoperative complications, though, didn't have statistical significance. So the discussion, the 26% of the laparoscopic cases required conversion to laparotomy. The remaining cases were managed laparoscopically. So, and also we found that the passage of flatus and soft diet consumption in laparoscopic group is significantly faster. These were our studies which were internationally compared. And I would like to call upon the last para, that is 73.4% was a success rate in laparoscopic group in the study done by O'Connor et al. And this was published in Surgical Endoscopy in 2012. So in conclusion, the laparoscopy for intestinal obstruction has a definite role if the cases are chosen properly. The therapeutic role in terms of adhesiolysis and biopsy is very useful as it prevents a laparotomy if done in expert hands. The return of bowel movements and ability for oral intake is better in the laparoscopic group. Here, one patient who had comorbidity of, he is a diabetic and also cardiac patient. He had multiple adhesions which were noted by the previous IPOM. We could reduce it laparoscopically and the patient recovered well. This was a small enterotomy which was noted on the laparoscopy, which we sutured with PDS. These are the adhesions which we have noted. And this was a small suspected gangrene with the umbilical hernia, but when reduced, it recovered and we managed conservatively. This was the bowel gangrene which we realized and required a laparotomy following the laparoscopy. These were the dense jejunal adhesions which were noted on the laparoscopy, which we have released via laparoscopy. So these are my references. Thank you. Thank you for your time. Thanks a lot.
Shivram, will you go first, please?
Dr. Pai?
Yes, sir.
See, one of the problem in these cases is the port of entry.
Yes, sir.
So where did you put the port, sir, and also how did you, whether it was varus or an open technique?
So the main point of entry was Palmer's point. When we were not sure, we were going in an open technique only. Even in the Palmer's point, we would go with the open technique and following the entry of the camera port, then we used to insufflate the.
I think that data would have been very useful.
Yes, sir. Yes, sir. Yes.
Second thing is, see, in most of the cases were adhesions and obstruction.
Yes, sir.
And from your presentation, it appears you have not tried any conservative measures in these patients.
Yes, sir.
That data is not available.
Yes, sir. Yes, sir. The pre-op, if we have always managed them 3 days conservative management. Only following that, the patients were subjected to surgical intervention.
Why the bowel gangrene was not picked up by the contrast CT scan? Because you have done CT for all the patients.
Yes, we don't know the reason, but when we went in, we recognized the bowel gangrene.
Right. Dr. Lakshman?
Yeah. Sreekar, you mentioned suspected strangulation as a contraindication. What were the criteria you used pre-op to
sir,
consider
yes,
strangulation?
Strangulation, if the patient appears septic, sir, then we were not planning for avoiding, we were trying to go in earlier. So in these cases, we didn't go ahead with
any other more objective criteria?
The pulse rate and blood pressure, sir. If presentation with gangrene.
Did you have a cutoff? Did you have a cutoff number for that? Pulse rate, BP? In a study,
yes,
generally you have cutoff numbers. So you have a cutoff for a pulse rate, a BP, white cell count, the CT findings as Shivram point. Did you have criteria to know, or was it subjective?
Yes, sir. No, sir. First, on the initial presentation, if the patient had guarding rigidity, we wouldn't take them up for the study. Okay. Only if after 3 days, 2 to 3 days, if they do not improve or they are coming with chronic subacute obstruction, then we would subject them for this study, not as an acute stage. That is what I meant. So if there is...
Do you have any data on how many patients of yours had laparoscopic bowel resections, either for stricture or perhaps a knuckle of ischemia or whatever? Or did you, when you had these problems, did you invariably convert them?
So we would prefer to convert them because the patients who come are not able to afford the staplers. These would cost almost 20,000-30,000 extra for the patient. So in general, we would not prefer to do about
Particularly in small bowel, you can deliver it outside the abdomen and do a hand anastomosis.
Hand anastomosis, which would be preferable.
Yeah.
So that we have done, but we convert them to laparotomies.
Right. My final question.
So
we have, when you compare two things to know
Yes,
which is better, which is not better, you need to have comparison of the patient data. While
Yes,
you
sir.
compared statistically the outcomes regarding flatus and food and all that, did you consider doing a comparison between the two groups to know that they are similar in terms of their comorbidities, their nutritional status, and time to admission and things like that, which also have a role in this?
Sir. I have this one, but I have not processed the data. But all of the cases, we have the time to admission and time to surgery. The standard it has been 3 days, but nutritionally picking up is not done, sir. Not done.
Thank you.
Yeah.
Thank you, sir.
So we come to the end of the program. I congratulate all the speakers. You have done wonderfully, like you have maintained the time. So I thank our today's judges, Dr. Lakshman sir and Dr. Shivaram sir. And we are going to announce the results on Friday after our session of the CSEP.
And Harish, the award will be presented on Saturday.
Okay. So announcement will be on Friday. They have to physically come to the oration program at 6 o'clock in the Capital Hotel on Saturday. So today I thank all our faculties, esteemed faculties, Dr. S. Ashok Godi, Dr. Rajshekar Mohan, Dr. Rajesh Balla, and our moderators, Dr. C.S. Rajan sir, Dr. Arun Kumar, Dr. Ravi Shankar HR for moderating the case discussion. So just tomorrow highlights I wanted to emphasize. Tomorrow we have a Dr. Case Shaker state level quiz. It is conducted in 2 rounds, preliminary rounds and final rounds. The preliminary round starts at 5:25 p.m. tomorrow. So the actual CSEP program starts at 5 o'clock. So followed by a case discussion, we are starting a preliminary round at 5:25 till 6:50. The final rounds from 7 to 8 p.m. So Dr. C.S. Rajan,
You have to invite Dr. K. Shekhar for this meeting.
Yeah, I invited. I called him personally. So Dr. C.S. Rajan and team will conduct the quiz. So Dr. Lakshman sir, anything to say about the
Harish, you have to mention that who are the people eligible for the quiz.
Yes, that we will send the. They have already done the registration.
It is, yeah. If I may come in, Harish.
Yeah, please, sir. Please, sir.
The registration for the quiz actually concluded at midnight on 20th.
November.
47 teams have registered. Tonight midnight is the deadline for providing proof that they are postgraduates, because the quiz is only open for postgraduates of Karnataka. It is a Karnataka state activity. 5 or 6 teams have not provided proof of their post graduation, so they will not be considered in the final event. As far as the layout, it has been communicated to all the people generally and has been specifically sent to the registered candidates again and again. 3 times we have sent it. There will be a preliminary round which only the registered candidates will have access to. It is done on a Google form. So the main Zoom platform, this platform has no access to that. It is only for the registered candidates. But in that half an hour, when the registered candidates are doing the MCQs on the Google form, Dr. Rajan will have a quiz, open quiz for all the audience in this audience. That will be in this platform. That will be between 5:30 and 6. Between 6 and 6:15, Dr. Nishanth L, a member of our team, will give the answers to the quiz questions, and we will analyze the first 4 teams, the top 4 teams, the rules and the way marking is done. All that has been conveyed to everybody. So the top 4 teams will then be informed and they will participate in the final round starting at 7 p.m. The final round is a Zoom platform round where only the finalists will answer, but the rest of the audience will be exposed to the answers and the procedure and the proceedings of the quiz, open quiz competition.
Anything else, Harish?
Yes, sir. I think we can conclude. Thank
No,
you.
one more thing, Harish. On Thursday evening, means we won't have any quiz after 8 p.m. No, nothing will be there after 8. We from the executive committee must have a meeting. Please schedule a meeting after this so that we discuss on how to go ahead with the oration program. Okay.
Yeah, I'll schedule the meeting.
Please do it as a separate
Yes,
Zoom
separate
meeting, okay? Not this platform.
Yes, sir. After concluding the CSEP, I'll schedule
Yeah.
a meeting, sir. Yeah. Thank you, Ananda, for your valuable presence.
Thank you and good night.
Good night. Good night.